Good morning, everyone. It's great to see you. Folks are trickling in right on the dot. For those of you early birds who came to get the inside scoop and just see us sitting here in our blazers, hello, hello. Loving that so many of you are already introducing yourselves in the chat. Please continue to do so, and we will ask you to do that in a more formal way in just a few slides. But for now, welcome to NaRCAD 2022. We're celebrating our 10th conference. This is a big day for us, a big week for us, and we're so happy to be here with all of you. Without further ado, I'd love to introduce you to our team. And for many of you, it's a reintroduction because we know you so well. For those of you who are getting to know us for the first time today, we hope to be close friends in the near future. I am going to turn it over to Mike Fisher, our fearless leader. Mike, let's kick off today. Good morning.
Wonderful. Well, thank you so much, Bevan, and thanks to everyone for being here. Welcome to NaRCAD 2022. I'm Mike Fisher. I'm the director of NaRCAD. I'm a primary care doctor here in Boston and the chief of general internal medicine at Boston Medical Center and Boston University School of Medicine. We're New England's largest safety net hospital, and just delighted to have you all here to celebrate this 10th conference session with us. Bevan, back over to you.
Thank you, Mike. And Mike is one of our co-founders. Our other amazing founder is Dr. Jerry Avorn. I will let him introduce himself. For many of you, he does not need an introduction, but we'll gladly take it over and again. Jerry, over to you.
Thank you, Bevan, and thanks to the whole team for putting together what looks like is going to be a wonderful meeting. I appreciate all the work that went into getting us to this point. I know many of you. For those that don't, I'm a professor of medicine at Harvard Med School, and with Mike, co-founder of NaRCAD, and have been very gratified to see the incredible growth of not just NaRCAD, but also of the whole academic detailing movement in the US and around the world. And I'm very much looking forward to today's and tomorrow's and the next day's session. So thank you.
Thank you, Jerry. And I love that it's a movement. That makes me feel like I can capitalize on that word soon in terms of branding. We'll be thinking about that. For those of you who don't know me and those of you who do, hi, it's Bevan Amira. I am the deputy director here at NaRCAD. I've been here for 8 years now, so I clearly love it. It's an amazing family and community of which all of you are a critical part. My background is in education, hands-on teaching, and also virtual teaching, as well as building virtual community networks. So I couldn't find a better home to be than NaRCAD, and I am excited to walk you through the next few days with my marvelous co-host, Anna Morgan-Barsamian. Anna, let's say hello.
Hello, everyone. My name is Anna Morgan-Barsamian. I'm the Senior Manager of Training and Education here at NaRCAD. And as Bevan mentioned, I will be your co-host along with Bevan over the next 3 days. We have been preparing something amazing for you for this conference programming in collaboration with our terrific presenters, and we are so excited to get started. So over the next 3 days, we will learn from leaders in the field and connect with all of you in our community. So thank you all so much for being here today. And now I'd like to turn it over to my colleague, Anshul Gupta.
Thanks, Anna. Good morning, everyone. My name is Anshul Gupta. I'm the program coordinator here at NaRCAD. Also really excited for these next 3 days with you all. And throughout these next 3 days, if you have any tech issues or have any questions, please don't hesitate to reach out to me and I'll be happy to help.
All right, thanks, team. All right, Anna, over to you to talk about our hub.
Yes, before we kick off, we have some housekeeping to cover. So the next 3 days are going to be filled with great information. Don't feel like you need to take it all in immediately. We will be recording these main sessions and adding them to our conference hub. So our conference hub has all of our conference content since 2013. We post videos, resources, and links that are shared during this year's conference. We'll put them right onto the website so you can come back and rewatch presentations or catch up on presentations that you weren't able to attend. So we'll have this content up for you all by the end of next week.
Thanks, Anna. And as she mentioned, you can check out prior conference programs such as the 2021 program book, but we're thinking you might just want to be in the here and now with us. And so for that purpose, we'll talk about housekeeping.
Yes. So if you have been to our events before, you know that we are an interactive community and love to see all of your faces. So please turn your video on and remember that these main conference sessions will be recorded. So if you do not consent to having your photo or video in our recordings, please keep your video off. We've all been in the virtual space for a while, but please adjust your view to speaker view if you'd like to see the slides and the presenter who's presenting side by side. If you need assistance with setting that up, you can reach out to Anshul and she'll walk you through how to do that. We also ask that you keep yourself muted when you're not speaking. Pet and kid interruptions are always encouraged. And please make sure that your name is correct on your Zoom screen with your pronouns listed if you're comfortable. This is so that we know what to call you throughout the next 3 days, and you might need to change that each day when you log in. And again, if you need any help changing your name, please reach out to Anshul and she can assist you with that. We will be staying on time throughout the conference to give all speakers their allotted time to present. Please keep an eye on the chat box for any updates from the NaRCAD team about any adjustments to the agenda. Speaking of the chat box, please use the chat box to ask questions. We encourage you to ask the presenters any questions that you have. We will do our best to get to all of your questions, and you can continue the conversation on our discussion forum after the conference, which we will tell you more about on day 3. And please remember to keep any patient stories you share throughout the conference anonymous. And a couple more items to cover here. We will automatically add you to our mailing list if you registered for the conference to keep you up to date on our offerings and news. And we never send spam. If you'd like to opt out, you can email Anshul by Friday or send her a direct message. And finally, as we've mentioned previously, please reach out to Anshul if you need any technical support. So this slide is what you will see come up after each presentation. This slide indicates that it's time for Q&A and discussion. If you have questions during a presentation, as I mentioned, pop those all into the chat box and we will get to as many as we can. Also use the chat box to network and connect with others that are here at the conference. We always love to have a very busy chat box like we have had this morning so far. So keep your messages coming. Bevan, over to you.
And feel free to share resources as well. Sometimes you all cut us, beat us to the punch in terms of sharing resources with one another. The first time we did this virtually, I remember someone saying, is there any literature on that? And 4 people posted 4 different links to literature. So that was lovely. So you guys are in control of the chat box. As we love to ask every time we do one of these types of convenings, remember this is an AFZ, which is an acronym-free zone. Many of us know some of the basics like HIV, AIDS, the CDC, etc. But if you are typically, ensconced on the day-to-day and something very specific clinically, make sure the first time you use it, you spell it out for folks. All right, Anna, back to you. We got a little fun piece here.
Yeah, so Anshul created something very fun for everyone to do. If you need a breather during the conference, you can use the link that she popped in the chat to bring you to a virtual academic detailing word search. So this word search is also located in our program book, which Bevan will tell you about right now.
And you don't win anything if you complete this except lots of self-satisfaction. And as we've seen, Anshul has been beautifully popping links into the chat box as we go. Just a reminder, you will get all of those in one spot. So don't worry about running the chat box, cutting and pasting. We're going to do that all for you. The other thing we've done just for you guys is show you online, since we're not sitting around holding printed books this year, which we like to see the upshot of as being great for the environment, even though we'd rather be able to sit next to you and do our word searches together. But you can learn more about our presenters, see very detailed session descriptions, read blog articles that have been specifically curated for you, and more. So check that out. All right, Anna.
Yes, if you haven't already, I encourage you to take a peek at our welcome letter for the conference from Bevan, our very own Bevan. It's in the program book and it's also on our blog. This conference is all about sharing innovations and excitement with one another within our community in order to boost morale. And that's what this letter is all about. So check it out to get ready for this week. Bevan, what should we expect for the week?
All right, so you've already kind of heard some of this. These won't be a surprise to you. We're all about connection and as much interactivity as we can muster without driving you bonkers. You get to decide how involved you get to be. If you want to step back, if you want to be more involved, whatever feels right to you. It's a spectrum here based on, you know, what you have available for energy and time, which is one great thing about a virtual approach. We want your thoughts. We want you to feel that you can find a way to connect with each other. And we also want your feedback and to talk about new opportunities. Anna's going to run us through the agenda and then we're going to get going.
Yes, so what does today look like? We're doing our welcome and our kickoff, and we are about to wrap up and hear from our director, Dr. Mike Fisher, with his address. Then we'll move into field presentations and we'll hear from our first 3 presenters of the day. We'll have a break. We'll do breakout sessions later this afternoon, which we'll tell you more about as we get there. Then we'll have another break and we'll wrap up with the panel. Throughout the conference, we are going to be using Poll Everywhere. And if you could just all take out your phones, it's the only time that we'll be asking you to do this, and send a text to 37607 with the word NaRCAD 1108. Now this will enter you into our Poll Everywhere room so that you will be able to answer our polls throughout the conference. And
Right.
once you do, you should receive a message that says you have joined the NaRCAD conference session.
All right, let's test this out, Anna. What do you think?
Let's do it. And Anshul popped a link in the chat box. If you can't get it to work on your phone, you can use the link in the chat. All right, where are you tuning in from? This is an example of an open response question that we'll be using. We have Wisconsin, Regina, Jacksonville, Florida.
It's gonna be warm down there today.
Oh yeah, St. Louis. Another one from Canada, Chicago.
So you all get the idea. Keep popping them in. We saw you do that on the chat box and get ahead of us there. We see a lot of folks from just across the globe. We've got someone from Australia here today. So that was just a test. We're going to give you one more test, so hang on there. We're going to go to the next screen. All right, so we know where you're tuning in from. Where do you wish you were instead? Let's get you to type that in and be real. All right, these are some older folks. Neptune, okay, we wish we were from Neptune. Looks like some people wish they were at the beach. I'm seeing just smiley flowers and hearts. I wish I were there too. The Turks and Caicos, yes. Mexico, Paris, yes, love it. Happy to do some French accents today to make us all feel a little bit more like we're worldly. And I love how many people responded to this versus the other question. We really like to be aspirational. And Takesha, we're sorry that we went too quickly. We'll have plenty more time to slow down for future polls. All right, Anna, here's one of our favorite polls.
Yes, all right. So this is an example of multiple choice. We're thinking of rebranding academic detailing. Please vote. Do you want it to be snackademic emailing, T for 2, or follow the evidence road? All you need to do is text A, B, or C into your phone to that number that we had sent you. That's also in the chat. And we are seeing follow the evidence road as a winner.
Woo! We're gonna have to come up with academic detailing the musical. All right, so now you know what's up. We are going to tell you a few more quick things and turn it over to Mike. As I mentioned, it's the 10th conference. We're super excited to say that since we saw you a year ago, we've hit the 1,000 mark of people trained. We're at 1030 here. We've hosted over 61 trainings, and we have a massive extended team of 10 expert training facilitators. If they are in the audience, you may be recognizing now that there are more than double of you than us. So if you want to, control things, you have a bigger number here. We also have a new training coming up. Anna, let's talk about that.
Yes, so we are proud to announce our first trainings of 2023. We have an AD 101 techniques training as well as an AD 201 techniques training. You can learn more about this on our website. Registration for both of these trainings opens December 1st.
All right, thanks, Anna. And a real quick overview, just to give you a visual of where we have been and where we are now. All of you have really breathed such amazing air and life into our convenings over the years. I remember Mike telling me that the first conference, there was just some fingers crossed that folks might come and show up. And now we've got 115 people here and growing as we go. Your innovations, your adaptations, and our ability to get you talking to each other, and we step out of the way a bit so that you can develop your programs in collaboration with one another, is what's made our programs over the next 3 days and all of the content at this conference really mind-blowing. But of course, Anna, where do we want things to always be grounded?
In the evidence. So you are all incredibly creative, but don't forget, programming is only as strong as the evidence. We need to make sure that programming is strong and evidence is of high quality. We want to find that sweet spot of evidence and creativity, and we're excited to explore that with all of you this week.
All right, so we're ready to dive in over to Dr. Mike Fisher to talk about an invitation for continued community innovation. Mike, without further ado, I want to give you the time you need to really explore some of this exciting stuff, a reflection on where we've been, some ideas about how we can dive even deeper and where we want to go. All right, everyone, thanks for getting us warmed up. Over to you, Mike.
Fantastic. Thank you. Thank you, Bevan and Anna, for getting us all set up. Thank you all for being here. It really is a treat to have a chance to set the stage for these next 3 days and share with you some of my thoughts about where we are and some of where I think we all have a chance to go together as a community to really invite all of us to join in thinking about what does the next phase for academic detailing look like as we move on into the future, as we adapt to the world as it is now. So the concept I'm going to introduce to get us started is the idea of disruption as an opportunity. Now, disruption is often used in the business world when people are talking about shaking up an industry, the way that Netflix disrupted Blockbuster's video rental, for people who are old enough to remember that kind of thing. But people do sometimes use it in healthcare, and I have to say, I'm sometimes skeptical about that we're in a complex business. Disruption isn't always a great thing for us. But I do think there are ways in which change is an opportunity. We've, of course, had a massive disruption the last 2.5, coming up on 3 years now. And we've talked a lot in our last couple of sessions, because they've had to be virtual, about how we've adapted to COVID. But there have also been some unexpected offshoots where we've had to think creatively. And as a community, we've done that. So what I want to do over the next few minutes together is think about what have we learned and how do we know what works? How do we determine how well the adaptations that we were forced to make in the face of these unexpected changes actually moved things forward, actually had the effects we intended? Among the many things we tried, some worked well, some probably didn't, and that's okay. Our task together is to look systematically at what was done, start figuring out how the adaptations work, and decide which ones to build on. So how do we inform our work with proven successes? How do we continue to be creative, to take risks? Well, we need to think about how we've adapted to disruption to set the frame. So, when we're thinking about this, we as NaRCAD, our first response was sort of a useful example. Frankly, we'd been skeptical of virtual trainings as a modality. It had been brought up, we'd held off on doing it, and then all of a sudden we had to adapt to it. And we had to try to make a virtue out of that necessity. As we've adapted to that, as we've conducted a larger and larger number of virtual trainings, we've begun to realize that some of those adaptations are highly effective, have been really well received by our community. So that's just one example. We've been hearing from all of you about the adaptations that you've made. For us as a central team, we can give you the larger perspective about what's happening maybe from a central capacity building role and the things that we've done, some of the trends that we're seeing. But all of you are the ones who are there in a given local context, trying to figure out what can I do to make my interventions work when I have various new restrictions on my ability to get in offices, when there's more stress on the system. And there have been so many different adaptations. We want to think with you about what kind of support do you need as we get back to more in-person work. We want to think together with you about what kind of in-person support and training you most need. What do you need virtually? We really want to learn from you about where, as a community, we all want to go, and to begin thinking about asking the questions about which of those directions will be most productive, which of those directions will have the highest impact for moving our field forward, for advancing our shared mission of improving the quality of care. The way we're going to go in that direction is by hearing your stories. Each of you understands the context in which you work, and you've shaped your adaptations to those contexts. But we want to understand from you how you arrived at those solutions. What about your changes is really specific to your context and maybe only applies to you, but what changes might be helpful lessons for programs that are similar in their geography, in their organizational structure, in the clinical topics they're working on, in any areas where we can draw more universal lessons, where we can figure out how can we as a shared field focused on outreach education, focused on quality improvement, pull out principles that we can apply across situations and also have context-specific changes. The more we know about each of your specific contexts, the better prepared we are when something similar comes up to be that resource. And for each of you, it's a chance for that story you've told about yourselves, what you've done, to have an impact in other settings, to have an influence on where the field goes. Now, as we think about this, we do want to make sure that we continue to set the bar high. All of you have been forward thinking in your approaches. You've been trying to say, where can we go with this? What comes next? We're going to, and that's one of the real underlying purposes of this conference. We want to create space for all of you to be learning and sharing. So over the next 3 days, I'm just pulling out a couple of examples that are top of mind here, but the whole agenda is absolutely packed with them. We've had the British Columbia program that had to create a detailing campaign in 1 week, which is the opposite of how we've usually approached it. And you'll hear more about that. The Veterans Health Administration program, which used videos and media in innovative ways to complement their AD work. There'll be that presentation. The University of Arkansas for Medical Sciences put a multidisciplinary team of detailers in the field rapidly to provide opioid safety education in new and different ways. And there'll be many other innovations that you'll be hearing about. So those are how we think about learning together. But we realize that while we've heard about a lot of adaptations in the field, there are certainly some we haven't even heard about. Many of you, we know that despite the outstanding work you do, despite the way you innovate, tend to be modest, not very self-promoting folks. It's why in our trainings, it's often challenging for people to get into that sort of sales mode of making a closing. And yet, you've done so much that's worth sharing. We want to hear about what you're doing. We want to know about colleagues. There are people out there doing academic detailing who aren't yet in touch with NaRCAD, and we want to be put in touch with them, and we want the community to learn what they're doing. These are opportunities for us to partner with you, to work together and take a deep dive into the adaptations that you've come up with and evaluate them. So one of the themes we want to weave through this conference is for all of us to be in a conversation about how we can partner together into 2023. We've been doing work to make headway on that. For example, we have a survey of academic detailing that's been in the field right now. Many of you have already responded to that, and we'll be in the coming year releasing those results. Exciting to give all of you a picture of where the field is, but just important, a roadmap for where we all can go. So as we think about how do we evaluate those successes, we do need to keep that framework that the innovations are important, but not just for the sake of all of us saying we did something new. The key question is what we learn from each innovation. As we think about how to do these evaluations, we're thinking about sort of the overlap between a more formal research structure, which has a critical role. Indeed, without the formal, proper randomized trials that Jerry did in the first place over 40 years ago, our field wouldn't have originally been proven and wouldn't exist. But there's also more rapid cycle program evaluation, the sort of classic PDSA, Plan, Do, Study, Act cycle that we're all familiar with, to sort of figure out how to improve an ongoing program. And so we want to think with you in different contexts. Where is there an opportunity for formal research to evaluate an innovation in the most rigorous possible way? Where is more of a sort of PDSA cycle, sort of a program evaluation approach more appropriate to keep things moving forward? Because as we figure out what's going on, we want to keep asking those questions. One critical framework I've been thinking about as we come to that is sort of the question of what is a successful experiment. When we're teaching younger researchers, we often talk about the sort of tell the apocryphal story of the young researcher in whatever field who says, my experiment wasn't successful. I didn't get the result I was expecting. And their wise mentor sort of gently sits them down and explains that that's not the definition of a successful experiment. When you learn from what you've done, whether it works as you expected or if it doesn't, when you generate reliable and valuable knowledge that can inform what you do next, whether that's reshaping the intervention you tried or figuring out how to enlarge it and broaden its scope, you've learned something that will help you take the next step. And so we want to have that framework with you. We know that you've tried lots of new things, and we want to set that expectation with all of us that not all of them will work. We're asking ourselves the same questions right now. Anna mentioned our first virtual training of 2023 coming. We're looking as we go into 2023 at what, in-person, hybrid, virtual, what we'll do going forward. We're asking ourselves which innovations have been really successful and which innovations do we need to keep working on. And we want to partner with you to have that open spirit of inquiry to keep moving our field forward. So really every innovation, every step, every intervention can create change, but we need to be ready to ask the challenging questions, to say, we assumed this would work, but maybe it didn't. We're going to be rigorous in how we approach it, be critical about our own work. And one important area I want to just take a moment and call out before we wrap on and move into the rest of the agenda is when we do these evaluations, we do need to be thinking about whether the impacts are what we expected and also whether the impacts of these innovations are equitable. As an example, I want to call on something that I realized in my own primary care practice, and many of us in clinical medicine did, when we think about potential unintended consequences, they can be positive or negative, of adaptations that we've made. So of course, in March 2020, all of us in clinical care very rapidly had to transition to virtual care. We, in a primary care practice, like where I practice, we basically stopped having patients come in. We had to sort of get them on the phone, on video. And actually, there were lots of remarkable improvements about that. We could We could see patients in their home setting and understand some of the factors that might make it challenging for them to attend to their health. Lots of useful things. But as time went on, we began to realize that we weren't reaching many populations who faced real challenges around economic or other social determinants of health. This was especially true for people of color, and that realizing that this digital divide that had been created was widening the gaps in access to care. Over the years since, we've been trying to remedy that, but I don't think as a clinical medicine field, we've quite done it yet. So all of us who are creating interventions to improve patient outcomes, we need to really be thoughtful, to be intentional in building in evaluations of the impact on health equity, on health disparities of our intervention prior to beginning it. That's one of the reasons we're excited about the inclusivity toolkit we've developed that Anna and Bevan will be presenting on day 3, as well as a range of other content you'll be seeing over this conference and in our future communications as we think together about how the innovations we come up with, how the interventions that we do impact directly in the ways we expect, what unexpected impacts they have, and how those play out for the many populations we serve. So I want to close by thinking with you about our enthusiasm for future explorations. All of you who are today are at different stages of your AD career. You may be AD curious, just joining one of our conferences for the very first time. You may be an AD ninja who can jump into any situation and deliver effective detailing messages. Regardless of where you are on that spectrum, each of you has something to add to this conversation, to the field of academic detailing, to future research, and to the care of the patients and populations we all serve. All of us have had to learn quickly how to adapt to the original model of academic detailing. And in some ways, that's been a healthy thing. It was, the studies that Jerry did originally 40 years ago were a remarkable breakthrough for the field. And as NaRCAD, we've often stuck very closely to that model. But we've had no choice but to adapt. And in that, we want to figure out how to embrace it, how to collaborate and partner with you, to learn together, to celebrate the successes we have, but to keep asking really challenging questions about what's worked well, what hasn't worked, and most importantly, where are we going to go together to keep building the field forward, to say that we're not just going to take what Jerry and his colleagues came up with 40 years ago and implement that, but we're going to keep building on it, improving it, making it more impactful as we move into the future. So we're excited to hear from you about that. We want to be partnering and collaborating with all of you in the community. But for the next 3 days, I really want you to look at the amazing programs that our committee and that all of you in the community have put together. It's a remarkable spectrum in terms of the topics, the types of the structure of the approaches, the geographic backgrounds, the professional backgrounds of the programs. It is absolutely inspiring. And I can't tell you how excited we all are to continue sharing that with you. So thanks for letting me take a few minutes to share these opening thoughts with you. I'll pass it back to Bevan now to get us into the rest of our agenda.
You're on mute, Bevan.
I promised myself I wasn't going to do that over the next 3 days, but I'm glad I did it early on. Mike, thank you so much for amping us up and reflecting on, what we really, really want to do over these next 3 days, which is, to think critically about how we can strengthen the work we do, but also really celebrate where we've come over, many years. And for some of us, just a reminder that there are many of you who just 2-3 years ago, this was your first foray into AD, and you are on the menu over the next 3 days. So for those of you who are brand new, this could be you too. So just remember a lot of it, a lot of who we are and what we do here at NaRCAD is to provide a space for you to talk about all those great innovations, to think about what worked and what didn't. And thank you again, Mike, for kicking us off. All right, Anna, let's talk about the exciting stuff that is coming up next. I'm really, really stoked for these this little grouping of presentations.
Yes, so let's start off our field presentations and hear from those programs who are adapting their academic detailing approaches, like you mentioned, Mike, in a way that can inspire all of us. We are about to hear from programs across North America working on AD projects to address diverse public health challenges that our communities are facing. Our first presenter is from New York City Department of Health and Mental Hygiene, which I know many of you have turned to for AD guidance. I'm honored to be able to introduce our colleague, Elizabeth Garcia, the Deputy Director of HIV Clinical Technical Assistance. Elizabeth's team uses public health detailing to expand implementation of emerging practices to end the HIV epidemic. She is the program manager and detailer for their immediate initiation of antiretroviral treatment detailing initiative. And Elizabeth, it is my pleasure to turn it over to you to share more about your team's detailing campaign on HIV treatment.
Awesome. Thank you, Anna, for the introduction. And I hope everyone can hear me right now. I am very happy to be kicking off field presentations for NaRCAD 2022. So thanks for the honor. And I'm really excited to hear from everyone and their respective programs over the course of the next 3 days. Today, I'll be presenting on our IART Virtual Academic Detailing Initiative at DOHMH. IART refers to initiating antiretroviral treatment, preferably on the same day or within 72 hours, to all individuals who are candidates for immediate initiation, whether a client just received an HIV diagnosis or whether the client is returning to care after a lapse. We consider a new HIV diagnosis to be a call to action, and our goal in providing AD is to empower HIV care providers throughout New York City to initiate IART on the same day as that new diagnosis. Next slide.
All right, it seems like we are kicking off with a poll, Elizabeth. So everyone back on over to your phones, to the poll everywhere text message. Go ahead and type in A, B, C, D, or E to this poll. What informs your detailing campaigns most? Is it input from the community? Is it your organization's priorities? Is it clinical or literature updates, epi data, or a little bit of everything? All right, what are we seeing here, Elizabeth?
So it looks like organizational priorities are kind of trying to beat up a combination of all of the above. Yeah, neck and neck, let's say.
But it looks like if we are just looking at the four on the top, organizational priorities could be even beyond A, C, or D. So is this surprising for you, Elizabeth?
It's not a surprise. There's so many different things that are involved in what we do. We have grant funders that we're trying to meet. We have ending the epidemic as our huge priority overall. And everyone is coming from a different place with different funding, different supports, et cetera, et cetera.
Thanks for sounding off, everyone. And if you're new and you don't have a detailing campaign for the rest of these polls, just kind of make a wish of, if you did have one, what you'd like to do. All right, but Elizabeth, show us what you all have been working on.
Great, thanks, Bevan. So we are the New York City Department of Health and Mental Hygiene. Apologies for the acronyms. I'll be referring to us as DOHMH from now on. We've been providing public health detailing since 2003. I've included details on the right there from Michelle Dress's experiences of public health detailing of primary care providers in New York City from 2003 to 2010. My unit is the HIV Technical Assistance, or TA unit, within the Clinical Operations and Technical Assistance program. Our mission is to establish strong relationships with clinical and non-clinical HIV providers and key stakeholders to deliver data-informed technical assistance. And our outcomes are to strengthen the capacity of the workforce and improve clinical outcomes among people living with HIV in New York City. Academic detailing is fairly new to our program. We use it to increase the New York City HIV workforce's ability to provide evidence-based emerging HIV treatment practices. Next slide. So in terms of our timeline, the New York State Department of Health AIDS Institute framed a new HIV diagnosis as a call to action in that Dear Colleague letter on the left. In 2019, the CODA program, that's my program within DOHMH, began planning its immediate initiation of antiretroviral treatment detailing initiative. That was the same year that the AIDS Institute published their clinical guidelines on IART, which they refer to as rapid initiation. We plan to deliver IART in person, but COVID changed IART detailing in person, but COVID changed that. Since DOHMH was focused on emergency response activities, we needed to adjust our timelines, as I know that many of your programs did as well. We originally planned to launch in 2020, but in November 2021, IART virtual detailing visits were launched. Next slide. The topic selection and key messages that we used emerged from data that we compiled from Ending the Epidemic technical assistance site visits in 2018 and 2019, where we visited clinics to provide targeted resources based on clinic needs. We completed 59 visits covering 101 primary care sites with locations shown on the left. We also used a citywide knowledge, attitude, and practice survey that was administered to providers by CODA, our program, as well as using anecdotes from providers that we collected during those visits. We had a stakeholder meeting in July 2019 to share our data and to engage in strategic planning. Next slide. So clinical and non-clinical providers at about 190 HIV clinical settings throughout New York City were prioritized for IART detailing based on rates of viral load suppression, caseloads, and rates of new diagnoses using the New York State AIDS Institute 2019 Cascade data shown on the right. Clinical settings were further prioritized based on whether they served ending the HIV epidemic priority populations. And that was based on our clinic survey. These communities include Black men who have sex with men, Hispanic and Latino men who have sex with men, Black cisgender women, Hispanic and Latina cisgender women, transgender people, older people age 50 and older, and youth and young adults. We also considered whether clients had lower rates of viral suppression within 3 months of a new HIV diagnosis for 2020 New York City HIV Care Continuum dashboards. We were able to access the data internally and through relationships with the New York State AIDS Institute, and the contacts we used were based on the ETE site visits I talked about earlier, as well as our program contact database. Next slide. So we originally planned to do in-person detailing, but again, as Mike mentioned, lots of shifts happened in 2019. So we had to shift from in-person visits to virtual visits. We're still only delivering virtual detailing visits. We are not allowed to enter clinic settings at this time. The detailers and myself are myself and a technical assistant specialist, as well as a project coordinator who handles visit scheduling and follow-up evaluation emails, and that's really been a crucial role. Visits are virtual via Zoom and 60 minutes long. We discuss up to 4 key messages, which is really unusual, having that 60 minutes. So we often squeeze in other resources based on how the discussion is going and who's participating. And if other toolkit resources seem more beneficial based on our needs assessment, we might discuss those resources instead. Sessions are generally one-on-one, but we do have a 3-participant maximum, so we've had some small group visits as well. Clinical providers are eligible to receive up to an hour of CME credit. We have a relationship with the Northeast AETC, who manages CME processing on our behalf. Next slide. These are our 4 key messages: focused on HIV testing, which is the start of the IART pathway; initiating ART as soon as possible, which we connect with our payment options guide; not waiting to initiate ART based on genotype resistance testing results, but to be sure to test all clients with HIV; and the importance of establishing an IART clinic workflow so that providers with different backgrounds and expertise can all work together to successfully implement IART. Next slide. We developed our IART Public Health Action Kit containing 13 resources relating to IART. These were developed using existing resources from the New York State Department of Health as well as the city. These resources were publicly available and included Dear Colleague letters, quarter-fold guides, and consumer-facing brochures. We wanted to build off of materials already created to make our internal approval process smoother. We also designed new resources to support key messages. Several were developed in conjunction with our HIV prevention program, with topics including those key messages that I discussed earlier. The toolkits are shared electronically during and after IART visits, during the visit via Zoom, and after the visit via an email link to download the file. Printed toolkits will eventually be mailed to clinic sites via USPS And for future initiatives, we're actually going to focus on electronic materials since we've had some procurement challenges with our mailing supplies.
All right, we got another poll here. So we want to know what tools you use to evaluate your AD programs. You can type it right into the text message. For those of you who haven't done that yet, think about what tools you would like to use to evaluate an AD program, whether you have one yet or not. And for those of you who have done this in various ways, feel free to add as many of these as you like. All right, so we're seeing.
You have to go to the pollev.com.
Meet you. So we see REDCap surveys, post surveys, prescribing data, feedback from CME forms, continuing medical education forms, lots of surveys here. I'm seeing some peer review, number of sessions tracked on Qualtrics. I love when folks share which, dashboards and such that they use, evaluations, lots of surveys. We'll take a couple more. Some folks are adding over in the chat box, measurement of the number of visits and both pre and post surveys, custom dashboards, looking at prescribing changes and prescriber data, some of which can be found on the PDNP. For those of you who don't know what that is, this prescription database, prescription database management program. All right, so this looks like things that seem like they're all in the same wheelhouse here. Elizabeth, back over to you.
Great, thanks, Bevan. And in our next slide, we talk a little bit about some of our tools as well. So in terms of evaluation and tracking, we send all providers a baseline survey prior to the detailing visit, follow up on their commitment after the visit at a mutually agreed upon time frame, and send follow-up surveys at 3 months and 6 months to try to gather impact over time. We use Outlook to email providers about detailing visits. As for tracking tools, we send providers a scheduling link via Calendly. I want to thank one of last year's NaRCAD conference presenters for recommending Calendly, which has been a really great tool to simplify scheduling. Our planning, monitoring, and evaluation team manages our surveys and evaluations using Alchemer, which was formerly Survey Gizmo. Our contact and event tracking is managed through Salesforce, where our project coordinator creates the detailing event and sends emails. And we track detailing visits for funder reporting using Excel and Word, and track all detailing activities we need to complete using Asana, which is a project management tool. And this is a sample IR evaluation question that's used in our baseline 3-month and 6-month surveys. We use the same knowledge, practice, and attitudes questions for all 3 surveys to try to measure changes over time. And then in terms of our quantitative results, as of October 4th, 22 of 96 contacted agencies participated in at least one IR detailing visit, which is about 23% of those contacted. Scheduling visits was a major challenge and required multiple rounds of outreach. We've completed 41 virtual detailing visits with 61 participants because we have visits with 1 to 3 participants at a time. 24 participants requested CME, of whom 11 have completed evaluations so far, and we've received 72 baseline surveys. So the number of surveys received is higher than attendees because we've had several attendees fill out a survey before canceling a visit, who were no-shows, or who filled out the survey multiple times when attending multiple visits. We've received 17 3-month post-visit surveys, around a quarter of our participants, and just 5 6-month post-visit surveys, which we started sending out in June 2022. It's been really challenging to get long-term survey response rates up, so we've been looking into incentives and other strategies in the future. We'd be happy to learn more about any strategies that have been successful in other programs. We've delivered 3 IR technical assistance sessions. These were requested sessions that are either follow-up after initial detailing visit or a large group presentation. And next slide. So in terms of the qualitative feedback we've received, based on the feedback we collect during our visits, the most popular tools are our payment options guide, which we use to highlight New York State's resources, including an online enrollment portal allowing clients to enroll in ADAP, the AIDS Drug Assistance Program, on the same day. And the IR Clinic workflow, which helps providers identify who will be involved in each step of the process to make sure IR is initiated as smoothly as possible. Participants appreciate being connected to DOHMH's HIV care resources and contacts within both the state and the city, including housing, ADAP, and at-home HIV testing. And next slide. Okay. So some additional topics and questions that we've discussed include these. Since we have a full hour to discuss provider needs, we often have time to address additional client barriers relating to accessing IART. So the medication isn't the only piece. We've discussed services for undocumented New Yorkers, supportive care resources, care for transgender persons, HIV medication diversion, which gives us an opportunity to discuss harm reduction methods. We've discussed addressing stigma, allowing us to model language use and discuss bias. We've discussed the long-acting injectable antiretroviral therapy and injectable PrEP treatment modalities that are coming up. And we've also talked about viral hepatitis screening and management. And I'm just highlighting some of the resources we have at DOHMH that our participants have been excited to hear about, including those housing, mental health, and immigration resources. In building our detailing relationship, the detailers become connectors, linking providers with Department of Health resources and contacts that can be nearly impossible to find otherwise. And then finally, in terms of our future activities, we plan to expand IART detailing visits to community-based organizations, providing HIV preventive services, and to non-HIV clinical sites, including urgent care locations, emergency departments, and university health centers. Visits are currently on hold because of our focus on long-acting injectable therapy, or LAI-ART. Our LAI-ART virtual detailing initiative will use lessons learned from IART detailing. In addition to training on content knowledge, we've realized that detailers must spend time becoming experts at tools like Zoom and Teams, so we'll be devoting more time to detailer training involving video conferencing technology. Scheduling and pre-visit planning take a lot of time, which needs to be budgeted into timelines. We are also planning to meet with providers over multiple visits to build a relationship that's sometimes missing after just that one-time visit, as we learned with IART. We included data from a provider survey we administered about LAI, showing that around 55% of HIV providers felt like they needed additional skills and experience to provide LAI, and our focus is meeting that need. And then for our next slide, just want to highlight this is very much a team effort. I especially want to thank my team members, detailer Gabriela Hermosi and project coordinator Brianna LaFortune, as well as my supervisor, Eleonora Jimenez-Levy. And next slide. And thank you. If you have any questions at all, feel free to reach out to me. I'll add my email address to the chat now.
All right, thank you, Elizabeth. So this was super helpful to get a sense of the sort of start to finish program, how you handled adaptations, especially related to virtual detailing, and not just to see that you were able to do it, but that you were able to do it in such a successful way, which really kind of lines back up with what Mike was sharing early in his presentation about disruption as something that helps us be innovative. I see quite a few questions here. I'm going to get to two of them. One from Joy Chai. Welcome, Joy. Curious, Elizabeth, if she's curious or they're curious, if you worked on other campaigns simultaneously, or was IART the major focus?
IART was our major focus. Thanks for the question, Joy. Since we have a really small team, it just takes a lot of time to get everything going. So we really try to focus on one at a time. When we do our LAI-ART initiative, we may continue to offer IART visits, but we're also waiting on some hiring delays for another detailer, and a lot of whether we can handle two initiatives at once will depend on our staffing.
Thanks, Elizabeth. We have time for another question, and I see both Dr. Fisher and Gwendolyn asked particular nuanced questions about the visits being 60 minutes, which again, for some folks seems unfathomable to have that much time. So we have a question around, was there any amount of time that ended up being less due to specific circumstances, and were those visits still successful? And Mike says, similar sort of piece of that, were there challenges getting that much time where people sort of put off? So if you could speak to that, that would be lovely.
Yes, so it was a lot to ask for an hour, and we understood that it was a lot. So I tried to offer after hours detailing. So sometimes I'd be detailing at 5 or detailing at 8 a.m. or earlier to try to squeeze it in before the provider started. I think CME was a good incentive for that, but there were definitely times where a provider said, I only have a half hour, or they joined half an hour late. And in that case, we tried to squeeze as much as we could into that time. It was definitely more of a challenge, and it's hard to let go of those key messages that you're used to going through. But at a certain point, you know, we knew that we weren't necessarily going to cover all the key messages, or they weren't all going to be relevant. So you just have to be really flexible.
Awesome, thank you. We are at time, so I'm going to table this question and have you two talk to each other a little later, maybe share on the discussion forum about scaling and things like that. Adapting from a New York City specific context to other areas. We're all about adaptations and trying to figure out how we can borrow from folks who are making a lot of headway. So with that in mind, Elizabeth, I'm sure this is not the last time we will be connecting with you. Thank you so much for being here today and for kicking us off with such lovely energy and a lot of positive feedback for your program that I'm sure will make folks feel enthusiastic about building theirs. Thank you so much. All right, so back over to you, Anna, to kick off our next introduction.
Yes, and thank you again so much, Elizabeth, for presenting. For those who came to our 2020 conference, you may remember that Elizabeth's colleagues presented on the IARC campaign when they were in the developmental stage. So how cool to see how far it's come. So we are going to head over and travel across the United States to our next presenter from Utah. It is my pleasure to introduce Adrienne Butterwick, the Senior Improvement Advisor at CoMagine Health. One of the many projects that Adrienne is working on is to provide educational support for opioid prescribing to family medicine clinicians as well as dental providers. Her innovative work with dentists has earned national recognition and has been presented on at the RX Drug and Heroin Abuse Summit and the American Public Health Association's annual conference. So thank you so much for being here today, Adrienne. And without further ado, I will turn it over to you.
Thank you so much. And can everyone hear me okay? I am on my phone in case the internet goes out.
We absolutely can. We indeed can.
Thank you. I appreciate the thumbs up there. So real quick, I do not have any disclosures to share today. I am just very excited to be here with you all. Next slide, please.
All right, we got a poll here. Everyone get their thumbs ready. What types of healthcare professionals have you detailed outside of primary care? And if you haven't, who would you like to detail? So thinking outside of the primary care box. All right, Adrienne, we're seeing the ER. That's not surprising. Some folks want to do dentists just like you, so they'll be able to learn from you. Another focus on dentists and OBGYNs. Yes, infectious disease, social workers. That would be an interesting application of the persuasive communication model and getting evidence into their hands. A few more, we have behavioral health, nurses, HIV outreach staff. These are all great ideas. Mental health surgeons. Yes, let's bring a couple more in. Cardiac surgery, APNs, pediatrics. Yes, this is all so exciting. And Adrienne, we're getting revved up with you leading the charge and talking about how we can make that shift to dentists, which is something that's been sort of in the works and in discussion for a couple of years here at NaRCAD, and we've had people start to do it. But I feel very confident that you're going to kind of push us into the ability to do that hopefully sooner than later. Pharmacists, medical students, and mental health, we're going to close up there. All right, so talk to us about CoMagine.
Excellent. Those were some great responses. Thanks for your participation, everyone. So real quick, CoMagine Health, we are, I'm not sure some of you may be familiar with Health Insight or Qualis Health. We joined forces and became one organization a few years ago. We operate in this 6-state region that you can see here. We're a national nonprofit healthcare consulting firm, and we're also the state quality improvement organization for this region. Next slide, please.
Sorry, just a little glitch. There we go.
No problem at all. And I do have a cold, so I apologize for my voice, but hopefully
Worries.
I have water in case anything goes wrong. So real quick, the slide that you're seeing here, and I do have to apologize that some of this information is a little bit older, and I haven't had a chance to really go back and update some of the statistics, but essentially what you're seeing is a snapshot of information from Utah from the years 2000 through 2019, looking at accidental and undetermined drug deaths by all drug types and all ages. And as you can see, in Utah, we have a bit of a unique issue. Our problem is not necessarily illicit drugs or non-prescribed medications or other types of drugs, but it is really the combination of prescription medications and non-prescribed. And so Utah has a slightly different need to focus on addressing how prescribed opioids are not just taking place through that practice, but also how our community is utilizing those and all of the other impacts that come with those prescriptions. Next slide, please. So for the purposes of this program, we utilized a hybrid academic detailing model, which I realize is a little bit different than the standard models that have been discussed previously and will be throughout our conference this week. We chose to focus on the entire care delivery team in our detailing sessions. And the content was tailored to the provider's region, specialty, and then specific interests. So we would show them our menu of information and have them tell us which ones they felt were most important to them, and we would address those first and foremost. And then throughout our 60-minute session, we would then hit on the rest of the information you can see here. So these are the topics that we covered. Next slide, thank you. So this is the timeline. So we started in 2018. We were funded through the Utah Department of Health Violence and Injury Prevention Program, which is funded through the CDC's Overdose Data to Action grant. And so we started in 2018. As you can see from the information, previously we were looking at prescribers and looking at prescription medications. We started in 2018. We did our first phase of academic detailing in the year of 2019, and then did some assessments, some evaluations, tweaked our program a tiny bit, and then did a phase 2 in 2020, which we'll discuss a little bit further as we go forward. Next slide, please. So this is just a snapshot of the Utah Controlled Substance Database, which is also referred to as a Prescription Database Monitoring Program, PDMP. So this is just, I just wanted to show this. Not all of us as non-prescribers or clinicians get to see the information that these prescribers access. And Utah has been working very hard to make sure that this information is very helpful to the prescribers and that there's a lot of information that can be accessed through this dashboard. So as you can see, we're showing the prescribers' usage compared by profession and specialty and state. So eventually we'll be looking to connect with our other states to see how your prescribing relates to peers in your region, not just in your state or county. And then it includes 4 patient metrics to help the prescriber's behavior, based on the prescriber's behavior, to help them understand kind of that patient picture a little bit further. There are some symbols here you can see. There's some color coding to help warn providers of some risky behaviors or of co-prescribing issues that might need to be addressed. All information that is mandated by the state of Utah to be accessed prior to a prescription. All right, next slide, please. So here are the results from our analysis. I did keep the results separate. There were just some confounding factors affiliated with our 2020 research and evaluation outcomes, and so I wanted to present them separately. So here's our phase 1 participant demographics. This is the mix of people in our phase 1. We did do dental and medical in both phase 1 and phase 2, but a lot of the tactics and a lot of the outcomes that we'll discuss today are very focused on that dental population. Next slide, please. And this is the phase 2 demographics. Essentially, we doubled the amount of providers that we reached from phase 1 to phase 2. Next slide, please. And so here are some of our results. So essentially, when we were looking at the number of opioid prescriptions with an MME above 50, as you can see, the blue line is before the training, and then the red line is at the after the training. And I failed to mention earlier that we did have an IRB approved research project here. So we were able to access the controlled substance database, their actual prescribing behavior before the training and after the training. And then we also had a prescriber survey that we administered directly to just the prescriber before the training, right after the training, and then 3 months after the training. So we were looking at their individual responses coupled with their actual prescribing behavior. So here you're seeing just the prescribing that has gone down. Next slide, thank you. Similar trend with MME greater than 90. So seeing some of these prescriptions go down as well. Next slide, please. So this one's a little bit different in that we're actually, because a main piece of our detailing was focused on access and utilization of the controlled substance database, we wanted to check whether that actually changed their behavior with the database itself. And one piece of education that we really kind of hammered hard on is delegation and proxy. So knowing that a provider, due to time and specific workflows, it may not be very easy to access the controlled substance database in a timely manner within the ways that the law requires that the provider does so. So there is a process to make a delegate or a proxy that can then go in, pull some reports for the provider and mark some notes. And so you can actually use your team to help kind of inform that database, but also use the information to help inform your care as long as it's done within a certain amount of time. So what we're seeing here kind of in a nutshell is that before the training, access was pretty sporadic. It seems to be kind of hit and miss. Maybe you had one patient that made you go in and look, or the state actually called you and said, hey, you haven't been using the database and you're required to. So now what we're pleased to see is just a more consistent access and use. And we have been told through anecdotal feedback that it really is the addition of those delegates and proxies within their workflow. Next slide, please. So here's a very ugly graph. I hate to show this, but it is what it is. It's what we have to show. I think all of us really understand that 2020 was just, who knows what it was. I don't have a label for it at this point in my life. But honestly, you know, what we're seeing here is the results that we were looking at before our training was expected to start, which really perfectly lined up with the beginning of the pandemic in 2020. So unfortunately, it's really impossible to know if our training had an impact on prescribing, mostly because we know what took place during the pandemic where certain procedures were put on hold, especially within the dental field. Individuals who may have had care had to be postponed and then were given prescriptions and other types of therapies to kind of make it through those shutdown periods of time. So we are going to be doing a little bit of assessment on pulling out more of that prescribing data now that we have a better picture of what happened and we can better tease out those factors. I didn't want to not show this graph, but it is definitely not a very clean-cut analysis of our training impacted, you know, these areas in the phase 2. Unfortunately, it's just it's difficult to tell. But I will say that similar to some other information that's been shared already, you know, we did have to pivot, right? So we went from doing everything in person with our providers to Zoom calls. And for us, we actually saw that increased participation with our providers. We were able to offer them wider amounts of time, knowing that we didn't have to travel to their part of the state. So we were able to do sessions at 6 a.m., at 7 p.m. We had a few Saturday sessions. And so we did have to pivot with the way we offered our programs and all of the other resources that we had available, but fortunately did not necessarily see an impact on how many people were able to access and utilize the training. So here's some results from phase 1. We did see an increase in self-reported co-prescribing of naloxone. The controlled substance database does not track that. Otherwise, we would have been able to couple that with actual prescribing data. Hopefully, that's something that will be changing in the future, as we know it's a pretty important metric to address. We saw an increase in providers with an office process for checking the CSD and kind of a more thoughtful method for prescribing. We also saw increases in confidence using the CSD and knowledge on referral for patients. Next slide, please. And then in phase 2, we had very similar results. essentially, greatest improvement has been seen in access to screening tools, improved skills for identification of misuse, and knowledge of referral sources. So we still feel that the program was impactful and helpful, but obviously we do not have as tight of data to kind of show that as we had with phase 1 and the prescribing data as well. Next slide, please. So that is really kind of the gist of our program today. I forgot to include a slide that kind of summed up the factors that I felt really led to our success. I think, like I mentioned, flexible scheduling, we've heard that before as well. Just being able to meet the provider when it makes sense for them and will be the most meaningful for them is incredibly important. We were able to still get the whole team included in these discussions. Our theory is really, it's important. We only had kind of one touch point, one resource available with our detailer, who was a prominent dentist and oral surgeon in our state at the Ross School of Medical School and Dental School. So we had a good colleague as our detailer, and he had very limited time. So we only had the one touch point. We couldn't say we're going to detail our prescriber and then we're going to come back and do a big group education. So it was really, we're educating everyone together. But what we heard feedback-wise, anecdotally from a lot of our providers was that, it was a nice kind of team building effort. It was also a nice way to address stigma in a group setting. A lot of people hold their own kind of thoughts and opinions, and when we're in a group and having these discussions, you could see people kind of open up and start to ask questions and start to kind of understand this information for themselves. We have a huge issue in Utah, as we do nationally, so I strongly believe that anyone that understands how to use Narcan is a win public health-wise for anyone. So a lot of our theory comes from the greater good. I'm kind of a public health, tree hugger, if you will. So really kind of wanted to live that spirit as well. We also saw, recent legislative or major health advances. We were able to say, we have the latest and greatest in our training. Did you know that the American Dental Association released a new white paper? And then we would also share with them some of the latest legislation updates and mandates that require their use of the CSD, that require certain prescribing behaviors. In Utah, they've changed how many pills you can prescribe for certain surgeries, certain things like that. Just wanting to make sure people are aware. Oftentimes people were not aware. A lot of times when legislation passes at the state level, there aren't necessarily funds for a communication or training campaign to go along with that. So we were able to kind of fill that niche. And then we had continuing education credits. I think it's a great comment that you should check your CME feedback forms for information. I have not done that, so I will definitely be asking for that information. Always learn something in these sessions. And then we offered free food. We always brought free food, no matter what time it was. And that was when we were doing things in person. But when we had to pivot to kind of digital world, we started sending them Grubhub gift certificates and different things to just say, go ahead, have lunch on us whenever it works. But thank you for your time. So just kind of the old model of, you always show up with free food and everything goes better. So, and then we do have some other programs coming up in the future. We'll be shifting to detailing surgeons. So I would love to share more as we learn about stepping into a new space, looking at surgeons.
Awesome. Thank you so much.
I think that is my time.
Yes, and to do that with a cold, beautiful. So lots of questions popping up in the chat box. If anyone else has questions, feel free to drop them in. And also some reflections. Amy is saying, I love all the data you were able to collect pre and post. That's excellent. And also a transition into an earlier question from our friend Elizabeth Valley-Mock in Maine. She would like to know, did you tailor the message differently when you were looking at dental versus oral surgeons? Was there a switch?
That's a great question. Yeah, oral surgeons are a very different group of providers. And it took us about a year to kind of build relationships to kind of get in the door. They're just from where we at Comagine Health don't have a lot of experience in the dental field, so not a lot of relationships to fall back on. Even our main detailer, who had been a past president of the State Oral Surgeons Association, still, it took us about a year to kind of warm that up. And then we were able to come to their conference and present there and kind of solicit more academic detailing with their full team after that. So you definitely have to tailor the message separately. I think that for us, we went to more of a traditional detailing model where we had our one-on-one provider to provider conversations at that conference. There's a lot of nuances in the surgery realm versus the general dentistry realm. And so we want to make sure that we're addressing what they absolutely need to know. And it is a very different message. They operate a lot differently than there's a lot of dental providers in our state. They are all private, individual, independent, so you can work with them one-on-one. But when you're looking at a system, oral surgeons tend to be affiliated with a hospital, a different medical system. So there are some other health systems to interact with along the way as well.
Excellent.
We did not go
Thank
to
you.
any other specialties.
No other specialties. Okay, great. Where I wanted to go with Lauren Rogier's question from Saskatchewan, with the data pre and post, was there patient or practitioner satisfaction pre and post? Was that part of what you studied at all?
We did not ask for satisfaction, but we did ask if they felt that the information provided on the controlled substance database was helpful. And I will be honest with you, we got about a middle of the road answer on that. And so we went back to the state to say, hey, have you considered aggregating your data differently? Are there some other tags or flags we can put on? Because we're hearing from providers that they're mandated to use this, but they still have other questions. They have to pick up the phone. It's not a one-stop shop for everything they need from time to time. So we didn't ask their satisfaction with our content and our training, more about the required tool that the state is mandating that they use. And, you know, there's still some room to improve that database.
You know, Adrienne, one thing that's so refreshing is that you are so humble and saying, I wish we had done that differently, or I haven't looked at that yet. I think there's so many of us that feel overwhelmed by how do we do this, and do we have enough time to do X, Y, and Z? And so you sharing that feedback really helps normalize the fact that we can't catch everything all of the time. Another question from Maine, did you look at the number of unique patients prescribed as well as the medication that was dispensed?
Yes, that's actually part of the analysis there. So what you're seeing is not sheer
this
volume, but it is.
Yep, sorry.
It is per patient, yeah. So understanding that there may be appropriate opioid prescribing taking place, but we're looking more at those other ones. And one of those slides, I don't know if I mentioned, specifically was looking at acute prescribing, which would be that dental focus. We're not necessarily concerned with individuals who do well and need a higher MME, and that is a relationship between them and their pain management team.
Excellent. And that's, that's a nice sort of flip side to look at, versus sort of a black and white approach. We do have time for one more question. Mike, I know you have some up your sleeve as always. So if you want to unmute and ask Adrienne a question, that would be lovely. And while you're looking at that, I just want to mention that in the chat box, our friend Brad Philbrick said, how do you get the budget for the free food? I threw in a response that might not be satisfying, which is if you want to make the pitch to leadership or whomever makes decisions on the budget, you could certainly cite that there are folks who have done this and it has been, helpful. Again, folks don't necessarily feel motivated to change behavior because they get a free sandwich, but it doesn't hurt to feel appreciated for your time, to feel validated, to just be kind of seen on that human to human level. So thanks for that. Mike, let's wrap up with one last question for Adrienne, and then we will move on to the final field presentation of the morning.
Excellent. Thanks for letting me have Mike for a sec. By the way, on the food thing, I would say for people making the argument, Sometimes the people you're making the argument to, it'll just be a categorical thing. They won't pay for food or coffee. But if it helps you gain access, there's a good argument that, a little bit of food or a little bit of, coffee and snacks is less expensive than a few hours of person time that might be wasted if your team can't get access and they're spinning their wheels, making calls and dropping by and so on. So an argument to think about. Adrian, great presentation. I'm curious in thinking about, for these changes in MMEs and so on, did you get insights into the sort of the process, how the clinicians were implementing that? Was it a case by case, or were they sort of doing more standardized protocols and thinking about how others will generalize from this? Is it the educational piece and sort of calling their attention, or do you feel like you have to give them a tangible tool to say, here's a way to do it?
I'd say it was a combination of both. It was we presented them with the statistics that, look, an individual, an adolescent who receives this prescription at a certain age is far more likely to develop, an addiction, and then having these pills in our cabinets is how kids are getting them in our state. And so kind of tugged at the heartstrings on that. But we also then came to them with the latest white paper from the ADA that actually outlines what you should be using for each procedure. And for the majority of it, it's a combination of ibuprofen and Tylenol. It's a synergistic effect. It does well. All the other things that we're aware of. Of course, there are patients who may not be able to tolerate, NSAIDs and certain things. And so there's other care pathways that you can look into. But we were very specific in saying, you should be prescribing this many pills for a tooth extraction. You should be prescribing this many pills for this. Have you considered hot and cold therapy? We actually had one practice say, we started buying ice packs for our patients. And we would just send them home with an ice pack. And then if they needed more, they would call us and we'd talk further about what pain medication might be more appropriate. I think the biggest challenge was really in those rural areas of our state where their practice of prescribing more medications because their patients drive 100+ miles to get to their pharmacy or their dental provider. And that's where we had the highest level of resistance. And it's because there are not very many community resources available, and providers want to make sure that their patients are cared for when they get home. So we still have some work to do on kind of the rural and frontier parts of our state. And I did just want to make a quick comment about the funding. We were very fortunate to receive a gift from the Intermountain Healthcare here in Utah. They were very, their prescribers, their data is all pretty great. Like, they don't have a lot of issues. They've put a lot of stopgaps in place in their EHR. So they said, we'd like to give you this money to go out and target providers that are not in our system. And so we were able to use money unrestricted as a gift to say, it was just a very generous donation, frankly. So I do acknowledge that you cannot fund pizza in your CDC grants. I do understand that, and it is definitely a challenge. But I do think if you could make the case, and I'd be happy to share more details about this offline, that you wouldn't be competing with what's happening in a system, but that you would still be educating within the same community, and there's a win there. So I did want to share that it was a gift. It was an unrestricted grant of money that we were given from Intermountain Healthcare to supplement our work, as really the greater good for our community. So we were really fortunate there, and I failed to make that clear, but that is important. It's the first program I've ever managed where I've had that available at my disposal. So I acknowledge that it's not common.
Thanks, Adrian. We're trying to find the balance between aspirational and hopefully, trying to kick things up a notch. I think if we can, pitch things to leadership using the word incentivization versus pizza, we might make some headway. But for those of you who really want to make this happen and need some help thinking creatively, there are brilliant folks like Adrian, and there are also folks who have talked to us about how to make that happen. So feel free to reach out. Adrian, thank you so much for being with us today and kicking us off with Elizabeth. We're going to wrap up before lunch with our last presentation for our field presentation section. Anna, over to you to introduce Jen.
Yes, and again, thank you so much, Adrian, for sharing this approach to AD and the lessons learned. I had the chance to interview Adrian for our details blog on this exact project, so we'll share the link in the chat and you can learn more about her work and read our interview. So we are going to hop on the AD bus and head over to British Columbia. I feel like we are on the Magic School Bus. I am beyond thrilled to introduce Jennifer Carefoot, academic detailing pharmacist from the British Columbia Provincial Academic Detailing Service, which many of you may know as BC PAD. Jen has been a detailer with BC PAD since 2016. She was an integral part of the development of a COVID-19 treatment AD campaign that was developed in just 1 week. So it is my pleasure to turn over to Jen to share more about this campaign. Jen, over to you.
Hi, everyone. Thanks for the invite and thanks for hosting everybody at NaRCAD. Yeah, I've been detailer with the PAD servers for about 7 years, I guess now, coming a bit from a background of community pharmacy management, long-term care role. This is our 21st PAD, BC PAD topic, and we called this one our special edition topic, and you'll see why I'm hoping over the next bit of this presentation. Next slide, please. Here's my disclosures and financial support. We are a publicly funded program here in BC as well, so no food. As British Columbia's Ministry of Health provides the funding for the services of the BC PAD. I have no other conflicts of interest. Next slide, please. So a bit of the background about this topic. On January 17th of this year, so 2022, Health Canada approved Paxlovid brand name combination of nirmatrelvir, ritonavir medication to reduce hospitalizations due to COVID-19. So for treatment of COVID-19 in high-risk populations. And just prior actually to the publication of the trial that actually looked at this in February. BC quickly received Paxlovid doses and required educational sessions for clinicians in this province to ensure safe and appropriate use of this somewhat complex medication. So it was determined that the BC PAD team had the expertise on, delivering complex pharmacotherapy information and also had the outreach to clinicians in the province to enable them to support this quick community engagement. Just so you know, here's my Canada geography lesson. This is the province of BC, just kind of shows you everyone the outreach that this took. That's where I live, right there on the tip of Vancouver Island in Victoria. But BC is about the size of Washington, Oregon, and California put together, with a population just slightly larger than LA. So there's my Canadian geography made easy for you. There was about 7 of the 12 of us BC PAD pharmacists that reached out to this entire population of clinicians in this province. So we met frequently through multiple virtual meetings with our Ministry of Health and the BC COVID Therapeutics Committee, also known as the CTC. There's a special, really as kind of a special division of our BC CDC to develop we say here 30 minutes. This is, I noticed a lot of the other questions on one of the other presentations was, how long? 30 minutes. Sometimes these did take an hour, but essentially we wanted to provide quick snapshot of the overview of this material. And so 30-minute PowerPoint presentation, including eligibility criteria for this medication here in this province, dosing, drug interaction management, and then resources available for clinicians. Our target audience was physicians, nurse practitioners, and pharmacists working in both hospital and primary care practice. Initially, large group sessions were offered through like the Doctors of BC, College of Pharmacists, large hospitals, to try and reach as many clinicians as possible. And then individual detailers could reach out to their individual clinician, database after that as well. We also, again, I've heard people talk about Calendly. We also use Calendly here as PAD detailers. So education sessions could be booked individually, but they were also booked as group sessions through through a centralized service. So our admin was able to look at all our Calendlys and be able to book individuals group sessions through this kind of centralized service. And again, like the other speakers, we had to be really flexible. And when we offered this, we did offer early morning sessions, late night sessions, kept our calendars pretty wide open to be able to accommodate as many people as quickly as possible. Here are some of the results that and so yeah, it was Mike had told you guys at the opening remarks, materials were developed and we upskilled within a week. So that included, learning all the background information, developing the PowerPoint, meeting with the key players. And then from February 8th, which is really when we started, to October of this year, 7 of the 12 members of the BC academic detailing team conducted about 190 sessions, again, to approximately 2,200 participants. Again, thinking about the size of BC, we had pretty, widespread outreach. Sessions were conducted, either we offered virtually or in person for people that were doing in-person sessions. We did have a formal evaluation process in the name of a online survey after, and this is just a snapshot of two the pieces that I thought were the most important. So did this session meet their learning needs from participants? And showed that yes, 98 participants strongly agreed or agreed that the sessions met their learning needs, and 95% of participants strongly agreed that they felt more confident prescribing and making recommendations to support the safe use of this medication.
Amazing. We're going to hear from the audience now. Get on over to your phones. So here's Jen's poll. Do you think you could train on the clinical content and develop materials for a detailing topic in 1 week? And Jen, does this include, day-to-day substances like lots of caffeine and maybe not sleeping, or what are we talking here?
Yeah,
okay,
exactly.
Right. Yeah. So no chance is leading. I'm seeing a couple people feel really confident. 16%, 18% are like, yeah, I can do that. I can do it in like a day. But it looks like not likely and no chance are leading the charge. Jen, I'm sure that's not surprising.
Not surprising. Yeah, I don't think if we hadn't done it, I'm not sure that our team would have thought that this was possible either. But again, just strong support from like our leadership within the PAD team, and then external, support as well. Yeah. So here's this. Yeah, go ahead.
I was just saying, I'm sure adrenaline helps too. We can all do things that you hear the stories about, parents lifting an entire car when their kid is, nearby. So we'll think about adrenaline. But again, over to you, Jen, to talk a little bit about some of the results that you found.
Yeah, so this again, I kind of spoke it, but so you can see it in a visual graph, and the quantitative data here. The session met my learning needs. So again, 98% strongly agreed that did happen. And then the next slide, which is again, I kind of felt like this one was important. Felt more confident prescribing and making recommendations for the treatment. And again, 95% of people agreed. Or strongly agreed that because of these detailing sessions, this was able to happen.
Right.
In here, and so again, we do always, leave room for some of the, give us feedback on our evaluation forms. And then again, I kind of tried to do this in a word graph. I grouped things kind of in themes here. This learning experience could have been improved by the size of the font. If the word clouds indicates the frequency of responses that we got here. Most overwhelming, nothing, which I love. So, I put that in there, like, you guys did a great job. Nothing could be improved. So people wanted case studies. We know clinicians learn, some clinicians learn well using case studies. Essentially, we just, quite honestly, in 30 minutes, it's really hard to provide really hard to provide a case. When some of my colleagues were then providing these sessions to, medical residents or medical students or other learners, they were actually ended up putting some cases in there, but the 30-minute PowerPoint presentation, there just wasn't time to get all the information there. Interesting, other people wanted a clinical trial review. At the time when we first started, it was like really brief. We really didn't even have anything in comparison to other therapies, and it just didn't exist for the evidence piece at this time. Next slide. Oh yeah, results. Participants found, so again, what could be improved? And then one of the questions is, what did you find the most useful? And I think this is really good for our teams going forward. They found, links to the resources useful, drug interaction checkers. There was a special prescription that our ministry put out that was really kind of almost like a checkbox algorithm, which I'll show you in a minute for prescribing. Everybody loved that because you had to go through like this, thoughtful process and to be able to prescribe. The comprehensive format and presentation and study details and step-by-step guide on decision making. And then the next slide is, just kind of grouping again this feedback and the responses, resources. They found the resources most useful, the drug interaction checkers, the drug interactions examples, the positive, overwhelmingly, we had great presenter. I put mine on there because I can. Often our detailers were called out, but I love this one. I think Jennifer is just great. So I included that one to show you guys because I could, but often individually our detailers were called out on here. But just an idea of what these drug interaction examples and the drug interaction checkers look like in terms of the style and the content. I'll show you a slide. Next slide, I think, Bevan, is where those were. And so they found these super useful. Yeah, so this was an example of the drug interaction checker, again, that our COVID therapeutics committee put out. Clinicians were encouraged to use these specific ones because they were specific to treatment with Paxlovid, which is only for 5 days, not treatment with ritonavir, which is what Lexicomp and the other interaction generally flag it for. And what you do for 5 days is different from what you do for the full time, or if you were on that lifelong. You can see the slide isn't pretty. This is normally not, there's too many words on the screen, but essentially the slide isn't pretty because we didn't have time to make it pretty. It was like, this is what the resource looks like, and this is where you can find it. Yeah, and I can see there, Angela's like throwing up the practice tool up there. So yes, exactly what we did, just show them how to use it and then provide the resource.
Right.
And then some real life examples of drug interactions. So commonly used medications and then what we would do. This one, people loved this. Sometimes some of us, depending on who we were talking to, pharmacists, we had a few hidden slides of these that you can really go through and be able to discuss this. Yeah. And again, providing the resources. We didn't provide participants with the actual PowerPoint presentation, which is some of the feedback that we got. People wished that they would have had that, but essentially we couldn't because the information was quite honestly being updated on a daily basis. And I can see, Taryn, our PAD manager is in there. It was really only possible because there was other people, the CTC, developing the resources. So we just provided participants with those resources after, not the PowerPoint slide, because that was really, the slides were time stamped and we wanted people to be able to access the updated information. And so this was an example of the fillable PDF. Again, not a pretty screen for you guys to look at. This is quite honestly what we'd show exactly in detailing sessions. Here it is, but here's your link on where to find that. And clinicians found that super useful, and being able to use something like this fillable PDF. And again, this wasn't PAD developed this came from our ministry. So lots of support here. We just were able to show what was being used. And then that information then went on to a website with a video. This is one of my colleagues in Vancouver, Tanya Marshall. So the video was also could be seen on the website. So you could refer people that couldn't attend one of those sessions to the website where they could watch this video. And then all the resources were also on our ministry website. That's kind of it for me, but yeah, the conclusion and you know, the moral of this story is 1 week, it can be done. Academic detailing teams are, you know, well positioned with the experience of, you know, we're effective communicators. We have the admin support. We have the connection to prescribers. And again, as Taryn mentioned, we have the connection to other groups in the province that could support us and that we could support to respond quickly and deliver education for new agents. The PAD program is continuing. We're still delivering this topic, and I reflecting on one of the questions from the other presentation this morning, while we were delivering Paxlovid, we were still also delivering our other topics right now as well. During that upskilling week, nobody was doing other sessions. We just kind of blocked off our calendars, but we were detailing on other topics as well. This is, you know, one of 3 or 4 topics that we had going. But the PAD program is continuing to monitor, modify, and present this topic still as new information becomes available. We are currently on version 23 of the PowerPoint presentation, which again just drives home that message. Is exactly why we didn't share it, because then people would just have that time stamped, whereas the resources were changing in kind of real lifetime.
Awesome. Such a wonderful presentation. I want to take a moment to transition to the Q&A by reflecting on the excitement in the chat box and also asking folks to drop any questions in the chat box. So far, we've gotten to everything because presenters have been lovely enough to type some answers as we've moved onward. So we'll do our best here. Lots of exciting stuff. Melissa Christopher from the VA says, I love what you're presenting to support frontline providers in a rapid turnaround. It's critical to success during these times. I also want to flip some of this, folks saying this is so needed. A lot of these clinicians needed this information yesterday. It's sort of acute crisis zone. And also saying those of you who don't have the staffing of a larger group like Jen's, please don't feel like, you know, Mike talked about setting the bar high. This is high, right? This is a group that's been around for ages. They're, you know, thought leaders in the field. If you're not there yet, or if you know you'll always be a detailing team of 2, that's okay. We can help you make these kinds of adaptations. We can help you think about free or low-cost resources and supports within your community that can make you feel hopefully like this isn't all on your shoulders. So again, those of you who are already going into our lunch break thinking, I got to figure out how to get pizza and coffee and multiply my team and stay awake for, you know, 7 solid days. We are, again, setting the bar high, but of course we want to kind of drop into reality. And so some of these questions here are really great. And many of them are reflections more than questions. I do have a question from Mike. Can this example, and it's an example of how an AD program can be a resource to promote public health at large. Can this example be useful in making the argument for developing these AD resources on a standing basis in other regions. What's your take on that, Jen? Or is it perhaps that other regions are so different? What does your instinct say about that question?
Sorry, can you beeped out there? Like, was there?
I absolutely can. So the question kind of is here, and Mike, if you'd like to clarify.
I can.
Yeah, go ahead, Mike. Yep.
Yeah, Jen, I thought this was what was so fascinating about this is, you know, in addition to sort of this, it's a great story, which, of course, but the, you know, it makes the argument for the importance of AD. I mean, often it takes an extreme case to sort of understand something, and you look at this extreme case, you say, oh, there are so many other areas where clinicians need high quality information. So both this makes an argument for a program like yours, you know, the importance in a crisis, but also the importance on a standing basis that if you, you know, you don't have a resource like yours, then how do you respond? And so I'm curious whether you've seen any of the conversations or in your, you know, your colleagues in your program, or just for your reflections on how this helps make the argument for why AD programs have a role. And this is obviously self-interested. We're at the AD conference. We're all going to think it's a good idea. But how do we make the argument to that broader community based on an example like this? Because it's so compelling, or at least it's compelling to this audience, because we're all into this.
Yeah, no, I totally agree. Again, you know, with the evaluations and some of that qualitative and quantitative data that we had, I just think, yeah, absolutely. Like, we're totally needed, and we're pitted in that kind of unique spot between like frontline clinicians and then, you know, where the information is coming from as well. You know, I would probably leave that to on a more and you know, Taryn, you're on the call if you haven't you're on this or Lauren, who are sort of the managers of, you know, two of our really well established detailing programs in Canada. If you have a kind of a better answer for Mike for that. Yeah, capacity limits, how often it can be done. Yeah.
And at the same time, part of why, shameless promotion, we're here for all you guys, is to help figure out how you can work within your capacity, but also slowly and steadily start to build frameworks and systems within your program that are in place. So you're not starting each new campaign from scratch. So you already have relationships with the community and providers in place. So I want to say thank you to all three of you, Elizabeth, Adrian, Jennifer, for kicking us off with so much enthusiasm, for setting the bar high, and also for, you know, sharing your successes. We need to not just humble brag, but brag more, you know, and we'll have some time later in the conference to let you all sound off on things from this year that you feel really great about. It's easy to get sort of caught up in the, oh, we need to do better, we didn't hit this milestone. And I love that all three of you talked about the successes in your program, because that's something that, you know, we really want our community to feel good about. All right, Anna, let's transition here. What is coming up next?
Yes, thank you again to all our field presentations presenters for kicking us off, and what a great way to start day one. So we are headed into a 45-minute break. After break, we are going to go into our breakout sessions. You can find descriptions and Zoom links to the breakouts at narcad.org/breakouts or in our program book. You can choose one breakout session to attend. The breakouts will not be recorded, but slides and materials from each breakout will be shared on our Conference Hub webpage after the conference, in case there was another breakout that you had your eye on and wanted to attend. We have a breakout on AD 101. We have one on gaining access, and we have one on working with community organizations. Anshul has put the links to all those breakouts into the chat, as well as a link to where you can find the descriptions and learn more and choose your breakout.
All right, so we're going to take that lunch break. We want folks to stay logged into Zoom, correct, Anna?
Yes, and feel free to ask more questions in the chat, network with each other, stay logged in. You can turn your video and audio off, but please do take time for yourself, take a break, have a stretch and something to eat. And we will come back here and transition into our breakout rooms at 1 p.m. Eastern.
And please do come back right at 1 as much as humanly possible. Your breakout presenters are so excited. Have a lot of jam-packed stuff to share with you. Want to make sure they can rock and roll right at 1. If you have any tech issues, please let Anshul know. Thank you for a wonderful East Coast morning and whatever time of day it is near you. Have a great lunch, y'all. We'll see you in a bit. Thank you. Welcome back, everyone. We will take off into the afternoon's final session in about 2 minutes. So please get yourself situated. Throw your camera back on unless you are feeling like your camera limit has been hit for the day. We'll get going in about 60 seconds. Seen so many folks I'm happy to see. The familiar, the new, the folks that I'm looking forward to getting to know better, as is the whole NaRCAD team. All right, let's rock and roll, Anna, Anshul, and Mike. And we've got Jerry. Jerry is the first mate. All right, Anna, what do you think?
Yes, let's get started. I hope everyone who was able to join a breakout session enjoyed their time and learned some great things from your awesome presenters. We are extremely lucky to be joined by 3 expert women in detailing for our last session of day 1. Bevan will be moderating this panel, and you'll hear from 3 incredible members of our academic detailing community. They'll share insights about clinician relationship building, both in person and virtually, through building your own confidence and expertise as a detailer. So Bevan, I am eager to turn it over to you to further introduce this panel and these phenomenal ladies that we have joining us.
Thank you so much, Anna. I am particularly enthusiastic about this panel. 3 of my favorite women in detailing. Let's kick off. We have Alona Balsanova. She is a psychiatrist and a lead detailer from Safe Prescribe, Nebraska, a group where she was a founding member. And we are just so excited to have all 3 of these women who are all trainees at some stage in their journey and are now really leading the field in talking about everything from having empathy and recognizing other clinicians' humanity to ways to transcend the computer screen and still make those connections. And that's something I know Alona is terrific at, which you will see shortly. So lovely to see you, Alona. We have a fan favorite, Jackie Travers from Oklahoma City. She works in pediatrics, mainly focused on mental health with Medicaid patients. She's a clinical academic detailing pharmacist for pharmacy management consultants. And we're just so delighted to have her here. You may have seen her in previous panels, such as last year's panel focusing on how to connect with clinicians who express implicit bias during detailing sessions. And last but certainly not least is Lisa Webb. She is an academic detailer at the Baylor College of Medicine and a licensed clinical dependency counselor in Houston, Texas. She's particularly passionate about supporting clinicians and their patients who are challenged by substance use disorder in varying manifestations. And if you'd like to learn more about any of these organizations, you can check out the links that Anshul has popped into the chat box. But for now, let's dive right in. Thank you for being here. I'm going to ask each of you to give a 60-second pitch about a way that, well, not a pitch, really, a reflection on a way or ways in which being a woman in healthcare has impacted your career and your own development. So let's go left to right. We'll start with Alona. Welcome, Alona. Lovely to see you.
Thank you so much. I'm so excited to be here. And like you said, I was a trainee at NaRCAD just a few years ago. So it's exciting to be as far as we've come with Safe Prescribe. With regard to being a woman, I think many of us in healthcare know that there is just a gender discrepancy with regard to leadership positions, with regard to other elements that perhaps some genders are inequitable in terms of what they are able to achieve and the opportunities that they have. So for that reason, being in academia and having the opportunity to do academic detailing is something I think is so important as a woman, because I think it's a way for us to propel forward. It's a way for us to put our name out there and to meet new people and to develop connections that we otherwise may not have made if it were not for academic detailing. So I think, you know, in spite of some of the negativity that perhaps surrounds some of the women in the workforce and the health workforce issue, I think the silver lining is the idea of academic detailing. I truly think it transcends and it enables women to have an equal playing field. And it's something that I really value.
Thank you, Alona. And you know, something that I've noticed as you were speaking and have thought about with the NaRCAD team is academic detailing. Our field does tend to be predominantly women. And I want to think a little bit more about why that is as we move forward. But thank you for kicking us off. And I want to remind everybody here that this panel is not specifically for women. It is for everyone across the gender spectrum to think about the dynamics that arise throughout any interaction where behavior change is being sought, where connection and seeing one's humanity with another is being sought to improve health outcomes for patients, and also just to think about the intersection of different components of identity. Whether that's for yourself, whether that's for your colleagues, whether that's for the patients being served and clinicians themselves. And so we welcome comments in the chat box, but you know, would really love you to be thinking about this as applying across gender, across identity. Thanks for kicking us off, Alona. Love to turn it to Jackie. We're going alphabetically here. Jackie, talk to us, if you could kind of summarize in about a minute some of the major ways that being a woman in the healthcare field has impacted, you know, sort of your growth, your identity. What is it that you would sort of want to focus in on as a nugget to share with the audience?
Yeah, so I bring a slightly different perspective than maybe a lot of people. I was a stay-at-home parent for years. When my children were small, I went back into the field of pharmacy when my youngest was a third grader. So I've had the sort of traditional conservative time period in my life. I've had the working parent period in my life. I've had the academic learner period in my life. And so I think having that continuum of experiences, it brings a sense of empathy to a lot of different environments. And so if it's a new prescriber, I've been there relatively recently. If it's someone who's looking at maternal health, child outcomes, I have aging parents that I'm helping to take care of right now. So it's that depth of experience that I tend to draw on.
Thank you. Lovely. And yeah, it's important to think about, you know, our roles outside of healthcare and how that really impacts the work that we do, because we don't get to put who we are as human beings in a box so we can go in and you know, do the work that we do, and neither do the clinicians that we're trying to support. And that's something that we'll get to in just a moment. Lisa, talk to us. You have been in the field most recently of the three of you. Talk to us about how being a woman has, what that part of your identity what the impact has been on the work that you do.
So thank you for that lovely introduction. And I really want to just affirm the comments that my predecessors made, everything just being right on target. I think for me, because I'm a behavioral health counselor, there's a very high percentage of women in that realm already. And so I've been very, not that anyone else wasn't supportive, but I've been very supported in and had many women mentors in my career related directly to the healthcare that I provide. I sometimes will feel, and that's probably just my own personal, experience, but sometimes I will feel like I need to be more prepared than say a male counterpart for my interaction with a clinician. And then third, I really, because I am a counselor, it's in my nature to already be compassionate and a nurturing person. Not that, again, a male counterpart can't be, but that's just my own personal, some of my strengths. And I grew up with a couple of RNs as parents. So caretaking was already kind of in my wheelhouse. And I think that has really helped me through motivational interviewing and kind of helping the rapport building process in the very beginning of that meeting, and kind of being transparent, being transparent. So asking them, how can you, is there anything you can teach me in this visit today? So.
Thanks, Lisa. Thanks to the three of you. And I want to invite all of us here to be brave in saying some of the things that we think, maybe worrying about some of the things that we might say. Anything that is focused upon or discussed is certainly not meant to have a flip side that implies that folks of other genders cannot do things that these, three women are speaking about. So I want to say that up front. I also want to think about the ways that nurture and society impact who we are for those of us who identify as women. And of course, this can apply across the spectrum based on, if you're raised by two nurses, that's going to be different than other situations as you're growing up. And so what I'm really interested in, and I'll throw this question over to Jackie to start us off, is the fact that more and more as we've been expanding as a community and hosting these interactive sessions, quarterly, monthly, what have you, where folks get to talk not just about the hard science and the quantitative data that they're dealing with in their programs and what they're trying to collect. They're focusing more and more on qualitative. What are the stories being told between detailers and the clinicians? How are they, as Lisa just said, inviting the clinicians to share their stories, share their identity? And one of the things that I've noticed, and I'm sure Anna and Anshul have as well, is that a question that comes up very often during trainings, during these sessions I mentioned, during any peer-to-peer connections. I'm sure some folks would love a peer-to-peer connection, but we're talking peer-to-peer, is the question of, what do I do if I'm not the real expert? What do I do if I go in and meet with somebody and they think that I don't know what I'm talking about? And it may not surprise you that more women ask that question than men. And a lot of that, we could break that down for hours, but at the end of the day, we're talking about women mentors. We're talking about the ways in which there's a place for women, that there is, as Alona said, a unique opportunity in detailing to sort of level the playing field. And yet we do have a ways to go. So Jackie, my question for you is, when you're coming in and you're worried that expertise, and I don't mean you in particular, I mean any detailer, comes in and worries, I'm not expert enough. What is sort of, from your perspective, the main goal and the main identity of a detailer if we can either put gender aside or if we can talk across the gender spectrum. How would you, talk about that identity, that ideal identity as a detailer, and how might your description encourage folks who are worried that they're just not good enough to do this?
Yeah, I'm happy to speak to that. It totally resonates with me. When I was getting started as a detailer, that was one of my biggest fears, is I'm not going to be the expert in the room. They're not going to listen to what I have to say. And I will say that I'm standing on the shoulders of, in particular, Mary Liz Taduni and Amanda Kennedy, two amazing women that actually trained me and helped give me some of that confidence. And so surrounding yourself with people whose confidence that you can draw on when it's not your own is super helpful. We'll maybe talk a little bit about that later. But speaking to the not feeling enough, I would say that our job as detailers is to facilitate vulnerability. We're trying to create an environment where change is sustainable, where it's meaningful, where it's possible. And so if we're speaking with a clinician, we need to get to know who they are as a person. We're not going to be able to help them identify their practice gaps if we don't see into what their priorities are. Are they someone who is driven by metrics? Are they someone who is driven by efficiencies? Are they someone who has a heart for patient care? I mean, hopefully someone has all of those on their radar, but some rise to different levels of importance for individual providers. Maybe they have a heart for preventive care. Maybe it's acute care. Do they dabble in non-traditional medicine? All of those are kinds of things that help us see who they are and help us tailor our message as detailers to where they are. So of course we have a degree of clinical expertise, but if that were enough, we could just send them the information. We could email them our materials. We could, just send it in the regular mail, what have you. But our expertise is, in my opinion, most importantly, relational. We are experts in getting them to self-identify where they may not be aligning their practices with the evidence, and furthermore, see their way forward into making a change. So we just need to be there to give them a safe space. To me, it's at the heart of AD. And so without that safe space, we're really not going to know what's the most use to their practice. I kind of go to the quote, people don't care what you know until they know that you care. And so we talked about this a little bit in one of our breakout sessions, to demonstrate yourself as a helpful resource for them, someone who cares about their practice pain points. You're not someone who's just there to add one more item to their to-do list. You're not there to slap their hands. You're there to inspire them to change and then give them a map to help them, to draw on the phrase earlier, follow the evidence road. So I try really hard just to kind of wrap it up and put a bow on it, I guess. I try to approach every detailing session by being a curious listener, suspending judgment, and just really making it a safe space for them.
Thank you, Jackie. Lots to dive in there. As we're going, just for our creative sake, I know it's 3 o'clock, maybe our creative juices are waning, but any votes for who on our home team, you can type this in the chat box later, would be different members of the Wizard of Oz. Please let us know. Back to you, Jackie. That was really juicy, and I want to grab a couple of nuggets here. So you talked about the fact that, the expertise isn't the main focus. And I loved that quote, they're not going to care what you know until they know that you care. I have never heard that. I think it's gorgeous. And I think, this is a new kind of panel for us, that we've been moving into this style over the past couple of years. And again, thinking back to the first slides of today, the evidence is still the focus, but we're learning of equal focus is that relationship. And I love this sort of Brene Brown influenced era, take what you want from that or leave it. But this idea that getting to what is meaningful and inviting them to be vulnerable and share what matters most to them as a human and as a professional. And so, Jackie, this idea of thinking of a menu where you say, hopefully all of these things matter to a clinician, but what's at the heart of it for them? And so what you're doing there is really, not to overuse a very common phrase, but putting yourself in their shoes. So thank you for that. Really appreciate it. And see awesome comments in the chat box. We have an audience member named Cassidy. I apologize if I butcher your last name, Faf, who says sometimes positioning yourself as the expert, even if you do know more than the clinician with whom you're meeting, is not the best way to influence behavior, right? No one wants someone coming in and saying, I know more than you. That's not a great way to start a conversation about changing your behavior. And Carrie Meyer from Maryland says, coming in to address, as you said, Jackie, yourself as a resource, a collaboration is really the way to go. And I know all three of you do that beautifully. I'm going to transition to a question that focuses more on what we started to talk about with confidence, that building rapport, building relationships, and getting buy-in. So now we're touching on that sales piece. And that's another thing that many folks at our trainings are loath to touch. They think it's a little slimy sometimes. Once we get them focused on this is your passion, you're selling evidence, you're not selling a used car, there becomes this sort of buy-in for us as detailers and as a detailing community. But I want to talk a little bit about taking that expertise, taking the flip of that and saying, how do you go in knowing not just that it's okay to not be the expert, but that if you are the expert, you deserve to be there, that you deserve to show up and know what you know, and not be humble about that, while also not coming in and saying, I know more than you do. How do you strike that balance, Alona?
Yes, thank you for that question. I love that Cassidy and Carrie made those comments, because I was literally thinking the exact same thing. The flip side of maybe not being the expert is being the expert, and that comes with its own bag of worms. And for example, I am an addiction psychiatrist. I'm one of very few addiction psychiatrists in the state of Nebraska. I could count them on both hands. And I go in and detail primary care physicians, so internal medicine physicians, family medicine physicians, and they know, a lot of the time they've heard of me, or they know who I am, and they know that I have expertise in opioids, which is what we detail on. And so how do you go in there and not scare them, right? And yet be confident in what you know. And so that's a balance I have to strike all the time in coming in and being confident in what I know. And at the same time, recognizing the humility in not knowing what they do and not fully understanding their practice. And I think both Jackie and Lisa touched on this a little bit, that, we need to connect with the person that we're detailing. And we may be the expert in the content, or maybe not the expert in the content. They are the expert in what they do, right? And it's important for us to recognize that and to respect that and to honor that when we're detailing. So, one way that I choose to do that is by simply asking, well, tell me about your practice. Tell me about, what you see in your clinical care of patients with opioids. Are you seeing a lot of patients with opioids? Just letting them drive that, so that way I can understand better what the needs assessment might be and take it from there. But I think coming in, you can kind of be scary, I think, if you have a very specific area of expertise and the individual, may seem a little bit put off by that. So I think also giving a disclaimer sometimes that, hey, I'm here, you're not being singled out, this is part of a routine thing that we're doing, this educational effort. For us, it's from our state. So our state is sponsoring this for all primary care physicians, and just kind of lowering the tension a little bit off the from the get-go, and then launching into them leading the show a little bit before you kind of come in with what you have. And I have found that to be very helpful with making a connection with folks when I am the expert in the content that's being detailed.
Beautiful. I love that. Thank you. Two quick reflections. We have a question or comment from Lauren Regier, one of our extended family members. I'm noting that Dr. Balsanova uses the terminology have expertise rather than am the expert. That's great wording that Lauren zeroed in on. Was that intentional, Alona, is the question?
Yeah, that's a really interesting point. And I would bet it's probably my unconscious bias of women being experts, right? Even though I am a woman who is an expert. That would be my guess because I never caught that either. So thank you for pointing that out. I think that's a very good point.
It is. And it sort of ties into a comment I was just about to make before we transition to the next question, finding that balance, because no one likes someone who comes in and is cocky or aggressive, and yet minimizing ourselves based on our experiences, and especially with, you know, the ways in which women are taught to behave in professional settings, to kind of step back, to defer to someone else's opinion, whether it's someone older, whether it's somebody who is male, whether it's somebody who seems to have a stronger connection with, you know, leadership, whatever the case may be. So looking at our wording, looking at, you know, Anna and I have spoken about the tendency for folks to use words like, I think this might be, before they say something that they know is. And so that comment from Lauren is a nice way to bring it home, to look at your language, maybe record yourself practicing a detail. How many filler words are you using to sort of take your expertise down a notch or to soften things? And at the same time, Alona brings up a great point. Do you need to not quite soften, but watch the sort of flow between knowing what you know and offering clinicians the chance to share what they know? And again, it just makes me think of great doctors. You go in and meet a new doctor, the idea that they're the expert on medical care, but you as the patient are the expert on you, on your day-to-day life, on what you need, on what your circumstances are. And so I love that. Thank you, Alona. Lisa, I want to get to your background in counseling. I love that this is a piece that is really unique to your identity as a detailer. I want to know, when someone, a clinician that you're detailing, reacts with defensiveness during a session or is a bit prickly for whatever reason, how do you stay focused on the goal at hand? Do you redirect? What is it that you do? What sort of magic tricks do you have that might be particular to your being a counselor in this situation?
Well, you know, I'm going to always go back to my motivational interviewing. You know,
talk to us about that.
That is my favorite tool to pull out pretty much throughout the entire visit. You know, always having that, well, tell me more about that. Well, I see that, you know, you're reacting, you know, very excited about that. Tell me more about that. It doesn't have to be a judgmental word. It can be a word of excitement or intensity. But, you know, just really, you know, trying to always, I hate to repeat it, but, you know, coming back to my steps in what I learned in academic detailing, and I learned from NaRCAD in November and December and, you know, January, back when I first started this, is, you know, assessment, handling that objection, circling back. Tell me more about that. Why do you think you feel that way? You know, asking those questions to try and draw out from that clinician their answer, not my answer to their question. You know, and that's exactly the way it's important for me to work with a patient too.
Beautiful.
I mean, it is motivational interviewing, but it's also manipulative as well, you know, and trying to manipulate them into making them think, well, why do I feel that way? Well, why am I here? Well, what, you know, how do I want my practice to look? And just asking them to continue to give you the answers instead of me giving them the answers. Does that make sense?
Right. And I want to say it's not manipulative, it's persuasive, right?
Okay.
It's persuasive. And don't ever be afraid to admit you go back to those steps. Those steps are
absolutely
the core. Yeah, the core. And I really loved what you were saying, is the sort of, well, why? That goes back to something Jackie said, being a curious listener, right? Treating this as, ooh, I want to know more about that versus, yikes, I'm never going to get through to this person. So I love that, the openness. Lots of cute comments in the chat. So thank you for that. That's really helpful. And, you know, thinking about the different ways that anyone who is detailing brings their unique experience. So Lisa, you had an experience as a counselor, Jackie talking about, you know, how she grew up and, you know, the population she works with, Alona being a specialist in addiction science. I mean, these are things where not only should you, you know, be proud of what you're bringing as a human and a professional, to know that not every detailer is the same is fantastic. We're not training you at a boot camp where we want you to all go in and be exactly the same. And so bringing your own experience is not just okay, it's encouraged. So let's talk a little bit about you know, bringing your own experiences during a time where being able to see each other in 3 dimensions has been close to impossible. You're talking about vulnerability, you're talking about empathy. These words don't seem to align with computer screen. The first word that comes to my head when I think about vulnerability is, I don't know, an old-timey movie where people are crying. This is not what I see, you know, Zoom screens. How do you do this? Because I know you do it. I know you do it well. I would like to hear a little bit about relationships in person versus virtually. Jackie, I know you've had the most experience with this just because Lisa and Alona got sidetracked more with COVID than the years without COVID. So Jackie, talk to me. You've said you feel confidence, you've told me anyway, and some of our team, you feel more confidence, or you felt more confidence being in person much more readily than conducting a virtual AD visit. So talk to us about why and sort of what you do in person to build rapport that folks in the audience can hear and bring into future in-person interactions, because that is starting to happen again, we've heard. So.
Yeah, absolutely. I appreciate that question. I did virtual or did in-person detailing for about 5 years before any of the shift to virtual started happening. And we had even tried to do some virtual at the front end and just couldn't really get a lot of traction on it. And so we were exclusively in person for about the first 5 years. And so I kind of developed a pattern, kind of a way of approaching the visits, and it worked really well for me, continues to work really well for me. I'm kind of a detective. I ask a lot of questions, but I also do a lot of things visually. And so when I'm arriving at a practice, I look around, I look at the neighborhood, you know, I'm looking out my window right now. What do I see? I try to get a comprehensive picture of the neighborhood. Is it, are they the only practice that's around? Is there a hospital nearby? What's their access to pharmacies? Are there patients in a food desert? You know, kind of what sorts of resources are they going to have available? That helps me know what kinds of things I can ask of them. You know, I can't really ask them to use a particular resource that isn't available to them. You know, I can't ask them to do, just as an example, parental behavior training for children with ADHD if they don't have parents who are involved in the lives of their children. You know, so you have to have certain things in place if you're going to ask them to do certain things. And so in person, it gives me an idea also of sometimes the priorities of their practice. So if I'm waiting for the visit to get started, I kind of look around the waiting room and see, what do I see? Do I see public health posters that are up, or do I see brand name drug coupons? Maybe I see both. You know, is there maybe an obvious age demographic to the folks in their waiting room? You know, I've been in practices where I see half a dozen kids under the age of 1.5, all with very full diapers running around in very little clothing. And so it just kind of gives me an idea that they're seeing an under-resourced population. And so we need to kind of address that in some of our conversations. I've walked into practices where they have an unknown specialty to me on the door. So I go in thinking that they're a general care practitioner, and I come in finding that they are a substance abuse practice. And so, you know, having some of those things in person gives me a shortcut, so to speak. to know kind of where they are, where they're coming from, some of what their priorities are. It lets things be a little bit more intuitive. In the virtual space, I find that it has to be much more intentional. So I'll have to ask them those questions. So it takes a little bit more time. It's still doable. It's absolutely doable. But I have to ask them, so what do you have in your neighborhood? Are you close to a hospital? Are you, just some of those things you can get on Google, but some of it you have to just kind of ask them. Demographics and those kinds of things. You can only see just so much behind them in that little screen. You may be able to see a picture frame or outside their window, or something to kind of give you a little bit of insight. But the feet on the ground, eyes scanning around, listening to what's happening, that to me is a very, very valuable part of the conversation, of the interaction. And like I said, it just kind of gives me a shortcut into some of the areas that I can help them.
Thank you so much, Jackie. That was chock full of great ideas. We always think of you as the detective. And I'm wondering, historical detectives who you would, maybe TV detectives who you would relate most to, but we'll put that aside for more important things for now. What I loved about what you said that was, so positive without being directly positive is you can do this virtually. It's just going to take you a lot longer and you'll have access to different things. I love that you can glean things from the waiting room. That's not something we teach at NaRCAD. Maybe we should start saying that. Hey, what are you looking around and seeing? Can you be consciously, tuned into these details that might seem peripheral and maybe irrelevant? But yes, if you were to say, hey, I saw a crazy waiting room out there, you must be stressed. I'm seeing a lot of parents who during a school day, they're off, they're bringing their kids in, just to start this conversation. And Nicole Seymour from CEP says, not only is that something that gives you clues, it's a good icebreaker. So instead of coming in and saying, what can you tell me about your patients? You can say, I just saw a really unique cross-section of your patients and I couldn't help but notice X. Already you're building that relationship where you're showing you care about their unique practice. So I love that. So think about being a detective. Very important there. I want to throw over to Lisa and Alona respectively, since you both, as I mentioned, have more exclusively and completely exclusively for Lisa been in the not in-person realm. I want to ask just for a few quick minutes, how do you each create and maintain connection with clinicians during these e-visits? We've gotten a little taste of it from Jackie, but how do you make things personal? How do you, how do you pace things? How do you connect essentially? So Lisa, let's start with you. Can you give us a couple quick nuggets about, the ways you prepare to try to go deeper in a connection? How do you prepare in advance and what do you do during a session to have a strong connection with a clinician on a virtual visit?
Well, preparing in advance, I usually practice with my mentor, right? Especially if it's a topic that I haven't done, several times. I'll get her to practice with me at least one time before the visit. And then also something I wanted to add, just real quick, I can't let my head run the AD session. Does that make sense to anybody else? Because
tell us what does run it.
My head will be doing this and I need to be focused on what's the next step, what's the next question I need to ask. And so it kind of helps me stay focused and prepared in kind of taking charge a little bit, right, of the flow of the session. Because if I don't, it kind of can run away from you a little bit. As far as connecting, sometimes I have assistants in here by way of furry animals. My cat will jump up and her tail will be doing this. I think some of you have seen that happening. And then it's kind of a moment to say, oh, excuse me, that was, my assistant, and kind of breaks the ice a little bit. But as far as that, continuing with that rapport and the patient is always on my mind also. So when I deliver that, when I'm vulnerable and I deliver that information and I invite them into my home office, this is my home office. This is where I work out of. This is how I've always done it. You know, when Jackie was sharing, that's kind of how I was thinking, like, this is how I've always done it. So it's just, you know, second nature to me.
This is status quo for you to have your cat detailing. You've never not had cat detailing. So there's yeah. And as Anna says from our team, pets equal icebreakers, right?
Yes,
so there are
exactly.
pluses to being in this format.
Right.
Thank you for that feedback. That's great. I love keeping your, keeping your head in check. And one thing that you said about letting something run away from your control, it's so interesting. We use the word control a lot. We heard Alona say, let them drive, or let them take the wheel, or something of that nature. And Lisa, you're saying, well, don't let it get away from you. So finding that balance. One thing that some of you have heard me say, and I just really like this analogy, is when you think about the best teacher you ever had in high school, college, what have you, they're not the teachers who controlled the room completely. They're not the teachers that didn't let, folks talk. And they're also not the teachers who knew everything about the grapes of wrath, right? We had teachers come in and say, here's what I'm going to show you. What do you think? What do you know? And instead of, what do you know about this particular author, or here's a pop quiz to make sure you read chapter 2, it becomes, what's your experience? What would you do in this moment? And so thinking of yourself as facilitating the conversation and driving that car, holding onto that wheel, but letting the clinician drive the sort of maybe the sidecar. We're clowns here, but having a sidecar where they're driving, by sharing their own experience and showing you where they want to go. You keep it contained. So I love that. Thank you, Lisa. Alona, same question for you. How do you, maintain that connection during an e-visit? What are some of your nuggets?
Yes, thank you. Well, at the risk of sounding repetitive, I'm going to piggyback off of things that both Jackie and Lisa actually mentioned, because I think some of the same strategies that are used in person are actually used with e-detailing. That being said, I've never actually done in-person detailing, because when our program was just about to start up, COVID hit. So we have exclusively been virtual detailing throughout. And yet, things like sleuthing or acting as a little investigator, as Jackie mentioned, you can do that, in sort of akin to looking around the waiting room. You can look at what's in their Zoom background, right? Are they at home? Do they have an interesting vase behind them that maybe is from their travels in East Asia? I mean, there's so many different things that could be conversation starters. And also, are you at home? Like Lisa mentioned, home office. Do you have a pet? That's a conversation starter. Absolutely. And just paying attention to the little details, being able to think on your feet. You never really know what you're going to get with e-detailing. Whereas with an in-person, you sort of have an idea of like, well, I'm going into an office. With e-detailing, they could be anywhere. They could be on a beach. And so you kind of have to think on your feet and be ready to be flexible with your approach. And again, this idea of creating a warm atmosphere, making sure that there's not a power differential, that they're not put off by you. Again, striking that balance of confidence and yet empathy for, what they're going through and the difficulties they might be having in their clinical practices. And thinking with emotion, and not facts. They say a lot that it's not so much what we say, but how we say it. And, I didn't say that in a fancy way, but you know what I mean. And I think nothing could be truer, because, if you are coming at it from a place of curiosity, like, both of my co-panelists mentioned, and if you are coming from a genuine place of wanting to, as Carrie and Cassidy said on the chat, wanting to partner with them, which is an excellent phrase I'm going to take, and I think that shines through, right? I think when you're genuine, that shines through, whether that's in person, whether that's on Zoom. So I would actually say that very similar strategies are used, or just applied a little bit differently when we're doing e-detailing.
Excellent. Yes. And what I'm hearing across both settings is, using interpersonal intuition and interpersonal intelligence. And there's nothing wrong with narrating what you're doing. So going back to, kind of putting a gentle X on Lisa's word manipulative, right? And saying, you're actually just trying to see what's in what's in the landscape. And you can see that in person literally, and also pick up on body language a bit more. But virtually, you can say something like, I'd love to know just sort of what are the stress levels on your day to day? Because if I could, if I were there in person, I would get a stronger hit of, well, how's your waiting room and what's going on? So, if you could tell me what's your waiting room like right now? Is it bonkers? Is this a time of day when it's a little quieter? You can say the things you would have picked up on. And so some examples there. But speaking of asking, how stressed out are you at the moment? I'd like to have one more question before we open it up to the audience. I know Mike has a question. And for those of you, we only have about 15 minutes left. So I know it's the end of the day, but you've got these folks right here held captive. So please do ask them anything you want to know, especially those of you who are new to detailing. But thinking about stress levels, I'd like to ask, how do you show empathy to clinicians who might be so burnt out that they don't want to go into vulnerability land with you? They don't want to talk about, maybe some things that feel like they're too emotional. They're going, you're catching them in the middle of a day where they're really focused on efficiency. What do you do when you get a clinician that's just really not going there with you? Jackie, I'm going to throw this to you since you've been in the field the longest. Can you think of somebody that was just pretty unbudgeable in terms of trying to talk about, stories together?
Yeah, so one of the things that I try to always keep at the fore is to extend them the grace that I would want to have them extend to their patients. So they have patients that are coming to them at their worst sometimes. They're feeling bad and they're stressed and they're having whatever issues they're having. That may not be the time to implement change for their patient. Same kind of situation. They may not be in a place where this is the day to have the conversation. And so to use it as an opportunity to deepen the relationship, to let them know that I'm there to be a resource, to let them know also how important it is to fill their own bucket, because you can't dip out if you're empty. I've had conversations with providers who were considering going on sabbatical. And so I spent one entire session kind of basically just asking them open-ended questions. What do you hope to gain? How do you think that this will impact your practice? How do you think it will impact your family? And so we have a 7-year-long relationship. And so we've established that, that safe space that I was talking about earlier. And so it was that one particular visit was just a chance to kind of go down that pathway of what about a sabbatical? Because burnout is real. Earlier on, probably summer of 2020, we talked through statistics about how many providers are thinking of leaving the practice of medicine and how they wouldn't necessarily advise their family members to enter. And they're afraid at the time of bringing home illness to themselves and, disrobing from head to toe and showering in the garage and all those things that were so real many months ago. Thankfully, we're in a different place now, somewhat different anyway. But, just to let them, warts and all, just say what they need to say. There may not be anybody else that's going to let them say those things.
I love that, Jackie. And one thing that really struck me with what you just said is sometimes we go in thinking, I've got to get through 2 key messages. Leadership wants me to tick XYZ box. That, thinking, oh, someone says they're going on sabbatical. It'd be really easy to say, well, take care. Gotta go. I'm going to go talk to your neighbor. But you're not only learning about what that doctor, that nurse, or that, pharmacist is feeling in that moment. You can think about, this is probably a trend, right? I've been reading about burnout. I've been thinking about it. And so you can also ask them the stories that are personal to them, but also what are you seeing across the board in your clinic, in healthcare? How long have you been nursing? What's changed? So that you're using them, you're doing a little bit of not just detective work, but sort of an anthropological study in that moment. And just as Mike said today, no experiment, no intervention, you don't come away from an experiment where you feel like something's failed without gleaning anything new or useful. No AD connection is unuseful to you. Even if you learn, hey, this time of day did not work for Vishal. He does not want me to come into his office, which is not true because Vishal would let me come into his office in the middle of the night because he's the nicest person alive. But you learn something and you learn about trends. And so to value any time you have, and that's something that might be a thing you need to share with your team, with leadership, to say, hey, if I don't come away with a handshake that I'm definitely going to use this prescription, database, that doesn't mean that the connection wasn't valuable. So I just want to share that with the rest of the group. Mike, I know you have a question you are dying to ask. So why don't you throw it out there and we'll see who would like to snag it for an answer.
Terrific. Yeah, probably as much of a prompt as a question, but let me give the context, but also starting by thanking all three, really four of you for a terrific discussion, to really thought-provoking. One of the pieces I was thinking about in listening to all of you talk about the work is, in addition to the delivery of messages being effective as academic detailers, all of what you're talking about, there's also the the thought about sort of leadership and promotion. Yeah, Bevan stuck in there the question I had pinged over to her that I thought we should talk about a little bit. In healthcare, I mentioned that my day job is over here at Boston Medical Center, where we have a very large general internal medicine group. And the trend, our junior and mid-level faculty, and this is true in a lot of healthcare organizations, are increasingly women, people who identify as women, but the more senior leadership positions don't reflect that. There are things that are getting better. We have some remarkable leaders on this call. Melissa Christopher leads the VA's program. Tara Newman leads BC Pat. But the overall numbers aren't representative. And so I'd be interested in reflections on leadership positions. I think it ties in to some of what you all brought up at the beginning about some of the the gendered ways in which communication has sometimes been expected, and how this is reflected in the ways in which people have been signaled that it's okay to advocate for their own interests and so on. And so I would love us to be thinking about how do we as a resource center help more and more of the many outstanding women academic detailers become the next generation of leaders in the field, really be the ones who are saying where our field goes and where their healthcare organizations go. So I realize that wasn't a question as much as a statement, but maybe sort of a prompt to get your thoughts on that, because that's a journey we'd love to be on with you, and sort of an argument we'd like to be helping make for the field.
I love this, Mike, and I want to throw it over to each of these ladies. But before I do, I want everyone who's still with us, which is a nice group of over 100, to put one idea in the chat, one phrase of how we can get more women in leadership positions in detailing, maybe in a larger context of healthcare. So pop some ideas in the chat. I'm going to turn it over to Lisa. Lisa, what's one idea that you might have when you're thinking about how to get more women in leadership positions, or to have professional growth at the same sort of speed or rate as a lot of men in similar positions?
Thank you, Dr. Fisher. I really appreciate that question because it's definitely something that I continue to observe myself in the roles that I'm in. When I really honed in on how do we help women grow in leadership positions, and when I say we, I understand that to be NaRCAD. Okay.
Mm-hmm.
Keep doing what you're doing. Keep encouraging, keep training, keep having these open conversations, these vulnerable conversations with us in this type of environment where there's so many different walks of life and experiences, because I think the more that we learn about each other and each other's experiences, the more we can connect, and the more that we can identify that, you know, we're more similar than we are different in that respect. As far as, you know, seeing the upper level positions continue to be filled by a male counterpart, you know, there are some structural adjustments that need to be made. You know, there are some and again, that is not I'm not my wheelhouse as far as like how to reconstruct a corporate entity so that it can be more diverse and have better equity for its employees. But I'm willing to be a leader, and I'm willing to mentor other women and anyone who is interested in growing. So I'm hoping that is that's just my experience, and that's what I see. So thank you.
Thank you, Lisa. I mean, we're hearing offering your services, right? Sharing what opportunities exist. And I want to say something, and this is in no way to make anyone uncomfortable, but mostly women responded to the prompt I asked about how to get women in leadership positions. I want to hear more from the men who are here, folks who identify, you know, maybe as non-binary or from different spot on the gender spectrum. I think a big piece of, you know, what can happen is that the folks who are in leadership positions to make that space, to use their voices. I'm seeing a lot in the chat box about training, mentoring, having more sustainable programs versus short-term grants, which I think is also tied to, you know, looking at short-term grants, often having funds for lower salaries or shorter term salaries. And so, you know, looking at that and connecting it to the disparity in how women are paid and men are paid in terms of looking at that data. Kimberly says something similar, transparent pay scales and equality there. Again, a lot more for mentoring. So I like what Kathy says. It's not just mentoring, it's be ready to mentor. Don't wait until someone asks, offer. So that's another great thing. And, you know, folks across the gender spectrum can do that for and with one another, or to ask someone who is not in leadership next, what's your sort of arc? Can I help as a colleague? Can I help as someone who's been at this organization a few years longer, even if I'm not in leadership? We have the chance to mentor each other, not just from, you know, a sort of traditional leadership to non-leadership level, but from you know, making lateral connections. We have another question here. I want to make sure I get time for Alona and Jackie to answer the great question from Mike. And then also, folks, I'm loving what you're adding around racial disparities. Thank you to Keisha. Developing training materials that are specific to women. And Melissa says, create more positions by demonstrating the value of these positions. Many get the sense that working in AD, you're always proving your value, whereas other positions are identified without having expectation to prove that value. So what I'm hearing, Melissa, is this idea that once you're in the position, your value, your title and your value have been sort of ascertained, and there's not the degree of having to maintain and prove all of the time as you might with AD. Does that sound right? Yeah, and so that's something that's unique to our field, for better or for worse. Alona, can we have a quick nugget from you, and then Jackie, about one thing that maybe has already been mentioned, since we have so many great comments, that you would like to see happen to get women into more leadership positions as they would like to advance. Alona, what do you got?
Yes, well, I'm excited because I thought of something immediately, so I was excited to share it because Mike mentioned, you know, what can NaRCAD do to help with this process? And I think one of those things is perhaps to provide a little bit of background and education on how to develop academic detailing programs, because I think for myself as the lead detailer in our state, I was fortunate to be involved from the get-go, right? I designed our program, you know, in conjunction with the other individuals who launched it. And so because of that, I was able to, you know, be thrust into a leadership position very early on, which has now continued and offered some mentoring opportunities and things like that. But I think having NaRCAD provide a little bit of that background, you know, how there's different flavors of programs, how, you know, some maybe are grant-based, some are not, what kind of grants might help fund some of those, things of that nature, I think could go a long way.
So I'm hearing you say that when programs are started and women are involved in the ground level, they get to be part of that building if they know what the sort of menu of options are versus coming into an already established structure. Does that sound right? Okay,
Yep, exactly.
awesome. This is so great. We're kind of picking up steam right before we have to end. So I'm going to try to summarize some of this and then ask that you all keep these great conversations going. You can stay on and chat for a bit. And might want to just kind of go into 350, Anna, if you'll allow me, because I just really feel like this is going in a lovely direction. Jackie, real quick, what do you think about, one thing you'd like to see change for women to advance more than they currently are or have been?
Yeah, so I just want to echo the comments on transparency. I think a lot of it goes back to that transparency of salaries, transparency about who were the applicants for the positions, what were the qualifications of the applicants for the positions that either were not offered an interview or were not granted the position. Transparency in terms of who are the principal investigators for the grants that are funding the academic detailing. So yeah, just transparency.
I like that, Jackie. I think the more that folks see who's involved in leadership and who's making the decisions, that's an interesting and potentially critical way to continue to build. The other thing is thinking about the psychology of hiring, that a lot of folks in leadership want to hire people that seem like younger versions of themselves. That's not always true, but reading up on that, looking at folks wanting to find folks that they relate to. And so you also have this piece in AD or in other, positions that require persuasive communication, these sort of misconceptions that, perhaps that men can sort of seal the deal, and that when you think of business people, you think of a suit, maybe you think of a man. I don't know, but that's something that should be broken down and should be considered when there are these roles available. Another thing I want to say is the reflection, and Jackie, you brought this into my mind at the beginning of the panel, talking about your life outside of work. There are often questions to female applicants. How do you balance work and life? How do you balance family without even asking, do you have a family? But men seldom get asked that question. There's seldom a concern that there will be a pull between family and work. And so again, looking at the societal influences and the ways in which folks are, raised hearing these stories about who they are supposed to be and how they are expected to be. I have a great comment from Cassidy. She says, I'm not sure of the best way to word this question, but I basically want to hear thoughts about what you all think it means to be professional as a woman. The struggle with wanting to be perceived as professional and serious while also being oneself and using humor. I'll throw that to one of you if you don't mind. Lisa, I'm seeing you smile and I know you have a great sense of humor. So if you can give us a little distilled nugget about how you find that balance, the idea that, women are often asked, thank you for that. I see your little emoji. Thinking of women being told, well, you should smile more, and that not being shared with men too often. I certainly haven't heard it. Lisa, how do you find that balance?
So any of you who know me well, I'm goofy. That's my natural state. I like to have fun. I am often the life of the party. It's just my natural state. And I have a feeling that Cassidy is it Cassidy that asked the question? Is as well. That's just me being my genuine self. That's just me being transparent. I have to rein it in, and then there's appropriate times when I can put a leaf on my head and have silly, stuff on my face when I'm being vulnerable and being myself. So I also have a sense of humor. It just comes out. It just comes out when I'm interacting. And it's also a way of diffusing stressful situations. And so I think that those things that you mentioned, Cassidy, are extreme benefits to your personality. And I encourage you to be yourself and to be your silly self. And I personally have done a lot of professional work on that kind of thing. And what I have found is that the more myself I am, the better my job gets, and the more bonded I am with my fellow employers. So
Excellent, Lisa, that's wonderful. And again, and I love what Alona just said. The term professionalism has been weaponized against women, BIPOC individuals, Black and Indigenous people of color, non-binary folks, and anyone who does not look or act like those who are typically in positions of power, especially in academic settings, which, as we know, inform a lot of hospital settings. And so there's that to think of too. Certainly don't want everyone to feel like 13 minutes before 4 o'clock EST, we're all going to solve the structural issues with, inclusivity or lack thereof. But the fact that we're starting to get into this is so important. And I want to share that at NaRCAD, Mike, Anna, Anshul, myself, Jerry, we are very committed to continuing to make space to discuss these. There will never be one size fits all solutions, and things keep changing, and they always will, because we're humans, we're organic matter, and society continues to provide us challenges, curveballs, and then opportunities for growth. And so I want to thank all of you as we prepare to wrap up for having such a thoughtful and insightful conversation that's, led by Alona, Jackie, and Lisa. But also I am just seeing the chat box come alive with these ideas about what needs to happen, and a very confident sense that you all know what needs to happen. There's just a gap between what we want to have happen on the front lines and what's actually happening on the front lines. So how do we bring some of this forward? And I think for now, one thing that we might be able to all agree on is to keep talking about it, especially those of us who might be in positions of privilege, who might be uncomfortable to talk about it for fear of saying or doing the wrong thing. So again, it's not just, as we talked about with detailing, it's not about knowing the answers, it's about posing the questions. Hey, it doesn't seem that there are a lot of diverse folks in leadership here. What are your thoughts about that? Versus, I have a plan to change this company. So again, make things digestible, have conversations laterally, figure out what people are feeling and what they think about these situations. I'm seeing a trend here that this is the way that detailers need to approach clinicians, and that this is the way that our community can turn to each other to understand not what we think is going on, not what we hope is going on, but what is actually going on. And so it's 3:50. This has been probably the juiciest conversation of the day. We'll leave you wanting more and hopefully staying on to continue chatting with each other. Don't be shy to direct message one another. I'm seeing connections, sort of cross connections happening. And we will grab some of these notes and some of these ideas and resources. If you sit thinking about some of this, you do some reading tonight, you find a resource or a link you'd like us to share, please pop it on over via email to the NaRCAD team. And I want to thank Alona, Jackie, and Lisa for being part of such a stimulating conversation, and for all of you to join us in with that. Thank you very much. I am going to turn it over to my fantastic colleagues, Anna and Anshul, and they are going to walk you through our wrap up. Anna, what you got?
All right, thanks, Bevan, and thank you all for creating that space and conversation. It was so wonderful to listen in and be a part of that. All right, so back to our poll everywhere. We are going to take out our phones again, and if you don't mind, texting 37607, text the word NaRCAD 1108 if you are not in the chat, and just add, what was the most valuable thing that you learned today?
So thinking all the way back to the morning, we had breakout sessions, we had field presentations, we had the panel.
We had mics. Yes. Conferences, transparency, and fax machines, marketing ideas. It's okay to not be an expert. So much. Group discussions. And small
someone tell us more about the fax machines in the chat box? Sorry, I want to know what that is.
I have a feeling that's in the gaining access breakout.
Got it.
Getting in the door, new outreach strategies, Another one, people still use fax machines. Carrie saying that was her gaining access to offices. Commercials, using commercials to gain access. Yes. Not being afraid to try a new strategy, aim big, reach for the stars.
Clear definitions of my role. Yes. What are the boundaries of your role? I love that. Anna, what else?
I'm loving this one, be yourself. Another one for fax machines are not extinct. Partnering with providers, marketing strategies, building connections with the community, with each other, with us at NaRCAD, connecting with clinicians and physicians. It's okay to be vulnerable. I like that.
This is a lot of good stuff. If you only have a week, contact BC Brad. Love it. Love it. Love it. All right, let's go to our next question. So we have time to do a few more things. Yes, and moving along here, we'll see that some of your texts will bleed over into this one. Anna, let's lead us into the final question.
All right, what are you hoping to learn tomorrow? Again, you can just type that into your phone. What are you hoping to get out of day 2?
Or what's something you learned today that you want to know more about, that you felt like you got your feet wet in, but you want to know more? All right, we got great ideas I can steal from others to improve our program. Let's go back and forth here, Anna.
Okay, content development hacks and resources.
More real life experiences from peers. Yes, from peers.
More connections.
Staff training tips.
What is the academic detailing movie coming out?
We have a lot of different things here. We've got some sort of hot wing thing going on, and we've got maybe Wizard of Oz Part 2. So we'll need to clarify which movies you'd like us to ask the government for funding to make. Meeting more awesome people.
Continuing to learn from everyone and pro tips, those go together.
Campaign oversight strategies, hoping to learn more about developing the AD documentation.
Yes, menopause in Norway. This is a presentation we have tomorrow, our field presentation.
Yes.
Another one for networking, Bevan.
Yep, how to be a mentor, how programs fund, more about a sidecar. We got a clown show going on here. We got all kinds of stuff. All right, so just for the sake of time, would love to, oh yes, Jerry will be in the movie. That's the only way we're gonna get it funded. Let's talk about what's coming up tomorrow, Anna.
Yes, although I was really enjoying those responses.
Yes, I'm sorry, I just want to keep us on time.
Here's a brief look at tomorrow. So we are going to kick off day 2 with a welcome, and then we will hear from Dr. Jerry Avorn during his annual AD talk. This is a session that our community looks forward to every single year. So we are so excited to hear from him tomorrow. Then we are going to have some field presentations looking at unique applications of AD. We'll have a break after that, followed by another round of breakout sessions. Again, you can check out the descriptions online and you'll be able to attend one breakout session. We'll have another break, and then we will close the day with a panel on capacity building. We will wrap up for the day and share an evaluation that we'd love if you could fill out. Anshul will put the link into the chat box. If you fill out our evaluation and complete and submit it, you'll be entered into a raffle where we will donate $250 in your name to a public health charity from a curated list of public health charities that we have come up with. Please add as much narrative as possible to your evaluations and tell us what worked and what didn't work today. We really do read all of your feedback. It's extremely important to us and valued. So please do fill that out. We'll have another evaluation for day 2 and another one for day 3. And all of those days you will be able to be entered into the raffle for $250 in your name. So with that, we will wrap up. I will hand it back to Bevan. And thank you so much for a terrific day 1, everyone. We will see you tomorrow.
Thank you, everyone. Please stay on to finish up your evals. They won't take you long. It means so much to us for you to do it while you're fresh, if you can. We also do report these back to our funders. So it's really important for them to know exactly what you think, for good, for bad, for ugly. So please do let us know any and all of your reflections. Want to take a moment to thank everyone involved today, and again to invite you to what Anna described as a fantastic day 2. If you haven't seen Dr. Aborn do his annual AD talk, better get with it, because it is going to be awesome this year. Thank you to our panelists, our presenters. Thank you to you all for taking yourselves for a lunch break and a coffee break and being so involved in the chat and just being here with us. We couldn't do it without you in the audience. Stay on if you need anything. Otherwise, if you've got your eval open, feel free to sign off and exhale for the rest of the day. Thank you, everyone. Much appreciation.